afternoon, everyone. Okay, can you guys see my screen? All right. Thank you, Jacob, for nodding your head. I see Kristen. All right, how did the exercise go this morning? How did that go? Were you guys able to do it yet? For leadership? No, not yet. Okay.
Not yet.
Okay. Anybody have any questions on that? Not yet. Not yet.
Can you tell us again, Professor, what you want us to do exactly with the previous assignment?
With the
scope of practice?
Oh, the scope of practice. Just write out, like, just summarize the different points, like for LVN, RN, and just in those boxes, just summarize what it's about in each of them.
Okay.
I just wanted to know that you guys like talk through them basically. So you just have to write just a little synopsis of each of them.
Okay.
All right.
Even though we already did it during the lecture, or is that if we didn't do it during the lecture?
That's if you didn't do it. I think I have 2 teams that have to still submit for that. I checked. I think I had 10.
Oh, gotcha.
There's 12 teams. So it's just, she was just asking from last.
Sorry about that.
Tuesday. No, you're fine. It's just from Tuesday. Okay. Let everyone get in here. All right. Let's see if I can bring the chat up. I can see your screen. Okay, Valerie said that. Good. All right. Get all these features working if it kills me, which it has. And we're halfway through the semester. Tomorrow we're at midpoint, you guys. I usually always write midpoint in there, so I'll kind of know where we're at and how everyone's doing. Which is crazy, crazy, crazy. Okay.
If I make it through this next PEDS test, then I might be okay.
No, you guys will. I know it feels like you guys are, when you're seniors, you're kind of like, oh my gosh. It depends on the person, I know, but I know how I was. I was like, can I go work? Aren't I done yet? Is this over? That's how I was when I was a senior. I was like, I'm ready to work. And my counselor or advisor, I think we all had to meet with an advisor at that time, was like, yeah, you have a whole year left. I'm like, what? This seems long. This seems very long.
I feel the same way.
All right. How you guys doing with cardiac? Anybody getting there? So I was rounding at United Regional, and I was talking with Alexis and Madison up there. And there was, you know, all the floors for the most part has tele. So when you guys are at clinical this week, I want you guys to really start looking at that. And I know at United Regional, for instance, they have normal sinuses in green, AFib and A-flutter are in yellow, pacemaker, if the patient has a pacemaker, they're in purple. And you want to try to see if you can see that pacemaker spike on the EKG. And a lot of time you're not going to see the P wave, you're going to see the QRS complex, and a lot of times it's widened and that pacemaker is firing to get those ventricles to contract. So anybody looked at EKG this week or looked at the strips at all since they've been at any facilities? I know in SIM they were looking at it. So
last semester I had you know how sometimes they'll show a patient on their EKG on there, if it's like really bad, they'll show it on every screen.
Yeah.
Well, me and this nurse I looked at it and it looked really weird, and and she was telling me that 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 it had a pacemaker, because I was like, it looks like it has double QRSs or something. It had like an extra bump on it, and I never seen one with the pacemaker before. But unfortunately, we watched that person actually pass away, and then the pacemaker was still going. So yeah, it was a really interesting experience.
And how did you guys know how to turn off a pacemaker? How do they turn off a pacemaker? Because if the patient dies, that pacemaker will still go, right? So Kristen, did they turn it off? How did they turn it off?
I'm not sure. It was on a different floor.
Okay.
And I was wondering, I was like, I think something really bad is happening with one of our patients. And she's like, no, that's from the 6th unit.
Okay.
Like, I was like, oh, okay.
Yeah.
But
So
we still watched it. Their heart stopped. So it was pretty sad.
Yeah. So does anybody know how you turn off a pacemaker after a person passes away? You actually have to put a magnet up to it to stop it. Okay. So that's why you'll see in the crash carts, they'll actually have magnets in there. And that's how we turn the pacemaker off, is to put a magnet on it and it'll stop it. That's why someone with a pacemaker, like for instance, there was a person who I knew who had a pacemaker and it was slowing their heart rate down into the 30s. And it was because they had a name tag on and it had that magnet, and that magnet was stopping that pacemaker from working. So when someone was watching it, like, so you'll have people who have pacemakers and there'll be people in the hospital who are watching those. They call that patient and they're like, hey, what do you have? There's a magnet around you somewhere. And then it come to find out it was the name tag that they were wearing, and they had to take that off. Okay. So, I mean, that person didn't realize it. They started getting, I think, a little dizzy and not, feeling lightheaded, but they didn't realize it was because of that. Okay. All right, guys. So how's everyone doing? I was asking if anyone had any questions about the activities from this morning. So you guys can always ask me if you haven't gotten to them yet. They're a prioritization and the patient assignment, 2 scenarios, and the 4 patients are cardiac patients. So that's a good.
Is that due today?
No, you guys can, when I'll let you guys do it till next Thursday, I'll give you guys a week. I know you guys have a test. So if you aren't able to give it, I'll give you guys a week to do it. Okay. Does that sound good? Yeah, I wasn't going to make you guys and some people like to do it and get it done. So, all right. So let's, I dropped a lot of study items, some helpful sheets for you guys to look at and to practice. So I did that this morning, the ones that I thought would help with what we were doing. So we have 3 chapters left for cardiac. So we'll at least get through 2 today. And then also show you some pictures, and then we'll do some strips. So, okay, let's go through, let's do this first one, chapter 28 first. And then I'm going to flip over to some of the slides in D2L, and we're going to look at some blocks in between this. So, and then we can look at ones you guys have been practicing on your packet. All right, so if everyone can download that, I'm going to present chapter 28. So I'm going to unassign it to you guys. We'll start this presentation. Okay, so what we're going to be talking about is cardiac disorders, the structural, infectious, and the inflammatory ones, okay, in this chapter. So what you're going to see is you're going to see valves that aren't functioning well, basically, okay? So you're going to see regurgitation is the valve doesn't close properly and the blood flows back through the valve. You can see stenosis, where the valve narrows down, and sometimes it doesn't open completely, and then the blood flow through the valve is reduced, so it doesn't get as much blood from, for instance, the atrium to the ventricles. And then you can see valve prolapse, where the stretching of the atrioventricular valve leaflet into the atrium during diastole. So what I wanted to do, can you guys see and I can put these on later if you guys want to see these. Here's a slide that's pretty, you'll see a lot of, so I'm going to pull pictures back and forth so you can see. So this is just the normal valve where it's going through, it's closed, the blood should stay on both sides, and then it goes through. This is a stenosis or a narrowing where it's not getting through, or if it is, it's very small, and then regurg where it's going back. Okay. So if we look at this, it looks like a fish mouth orifice. And when you see pictures like this, and I know I've shown you before, these are hearts from cadavers, and you'll see them a lot of times. The organ is like a gray or really pale like this. So this is mitral valve stenosis with fish mouth orifice. And that's kind of what it starts looking like after the fact when we look at the person after they've passed away. Okay. This is a picture of the mitral valve prolapse. So what I want you guys to know is look how big that left ventricle is. See how thick that wall has gotten? And then look how that space is, you know, really narrowed, or the amount of blood that it can hold. And then here you can see the prolapse of that. Okay. And then the other picture I want to show you is this percutaneous transluminal balloon valvoplasty, where we float that catheter in. Like before, we were talking about the catheter that floats into the coronary arteries on the outside of the heart. This one actually floats into the heart, and then they put that catheter and blow up a balloon, and they can blow up 2 balloons, and then it can become a really big balloon to help open up those valves. Okay. All right. Let me minimize that and go back. So here we've got the semilunar valve with the coronary arteries on both sides. We have that tricuspid valve, and we have the mitral. We know we talked about left and right, where they are located. So if you cut this into 2, mitral and the aortic valves are the ones that you're going to see the most valvular disorders with. And why do you guys think that is over the like tricuspid? Or what do you guys think the reason that you'll mostly see mitral and aortic versus the pulmonic and the tricuspid? Yeah, exactly, more pressure. So so because those have that, the left side is forcing it out to the rest of the body, they get lots more blood through there, lots more pressure that they have to deal with. So you're going to see the mitral and the aortic being the ones with which you're going to have the most problems. Okay. All right. So what we need to do for these disorders is we need to educate the patient, right, on what's going to happen with this disorder. We're going to, of course, monitor the vital signs, which we're going to do with, you know, most of the patients. Monitor for complications. So the things that we're going to look at with the valvular heart disorders are heart failure. And you can kind of see from that picture why that would happen. Dysrhythmias, right? Different kind of rhythms in the heart. And then the dizziness and syncope, because we're not getting that blood out to the rest of the body, right? A big thing that we have to do with them is medication, schedule, and education. And then daily weights, monitor for weight gain. So the weight gain, whenever we talk about weight gain, when we're talking in relation to your heart, why are we wanting to monitor them for weight gain?
Edema.
Edema. And why are they getting that edema? What's not functioning well that we're concerned about?
The heart.
Correct. Yeah. So the heart's not doing what it needs to do. So that fluid is getting retained and it's backing up and it's causing all kinds of issues with the body. Okay. So the one thing that we like to do is monitor their weight. So we know if they're consistently not trying to diet, do all that stuff, they're taking medications, and we're giving them things like Lasix or heart medications, different types that we're going to talk about, then we want to use that scale and see if we can catch it quicker problems by watching their weight gain, because that can slowly happen or quickly happen. So they keep a consistent weight is what we want them to do. All right, so with these patients, along with cardiac patients in general, we want to plan activity with rest periods. So we still want them to do their activity, but we want them to schedule it out to where they get stronger and stronger, but then give them those rest periods and really encourage them to do that. And then sleep with the head of the bed elevated. So what are some different ways that we can elevate the head of the bed of these patients? What are different ways that you guys have heard of people?
3-pillow method.
You can use pillows. What other things can you see done? Yeah, wedge is good. It's finding a comfortable position. And you can ask, those are some of the questions you'll ask these kind of patients is, you know, how do you sleep? Do you have to have another thing that you can see a cheaper way to do it if the patient can't get one of those like hospital beds, or which we do that with patients when if they're going home, and insurances will pay for some of that, is we'll have them take cinder blocks and put the cinder blocks underneath the head of their bed to elevate it, and that's the cheap way to do it. Okay.
Or to
So-
sleep in a recliner, right?
Yes, and that's the other thing that people don't even, a lot of times people with such bad shortness of breath or heart conditions that have that pulmonary congestion, they will sleep in recliners a lot of times, and or on a couch where it's going to prop them up more. So, all right, here's the first question. So, and you guys can give me the letters. The nurse is providing education for a client diagnosed with mitral valve prolapse. What should be included in the teaching plan? So it says what, select all that apply. So I'm going to let you guys look at this, and you guys can just do it in the chat box. I need to put these in top up, but I haven't. So which ones do you guys think for this? Good. Okay. Give you guys a couple minutes to see what the consensus is. There we go. Good, good, good. Good. All right. Okay, so yeah, so you guys did good. You got most of them here. So it is C, D, and E. So avoid alcohol, stop use of tobacco products. We're always going to want them to stop smoking. And then prophylactic antibiotics are not prescribed for dental procedures. So a lot of times you're going to hear them talk about that there are certain conditions where we want them to take antibiotics. Has anyone heard the saying that if you look at a person's mouth, that can tell you what their heart condition looks like? What it kind of tells you your heart health by looking at their mouth, right? So it's interesting when they start talking about that, since they're to like start looking at people's mouth and then look, oh yeah, that is kind of true. You know, if they can't take care of their mouth very well, then their heart, you know, might have some issues going on there. Okay. All right. So that picture that I showed you with the valvoplasty. So there's different ways we can open up those valves. That balloon valvoplasty was that picture that I showed you. And I'm going to show leaflet repair, and we're going to see a couple how they're doing this. And there's some new procedures that they're doing to fix valves. Okay. The other thing that we can do is valve replacement, and there's all different types of valves that we can replace. Okay. So we're going to look at those. All right. So here is like this balloon valvoplasty to get over to now the right side isn't an issue. You know, if we had an issue with the tricuspid, but we said most of it's happening on the left side, right? With the mitral valve. So what they're doing is if you guys look, they're going up and then they're cutting across, they're going across through the right atrium to get over to the left atrium. Okay. So they're using that and then inflating that balloon. So they're going to have to make a little hole to get across there, or sometimes I think they were showing you the coronary arteries, but to get over there to open that up. Okay, so different ways they'll do it depending on the patient's heart. The annuloplasty ring insertion. So they do this where they use sutures and they have a little plastic piece that they're going to put and sew it in there to help with that valve. And then they're showing you again how they're resecting it and repairing it with that ring here, where they're doing sutures and how they're gonna fix that. And then they're doing a valve replacement, okay? So they're going to be using these sutures. They have this orifice that they use, and then they have this prosthetic valve that they're using. Let me see if I can pitch it. I'm gonna pull up this picture again. All right, so here's the different ones that you will see. And you can see this in your book, but I like this picture better. It was easier to see. So these are the types of prosthetic heart valves. So you've got this, and a lot of times when you hear a name, it's usually named off either the first person who got it or the person who created it, right? So this is a Star Edwards caged ball valve. So that's what that looks like. This one is the St. Jude bi-leaflet valve. More than likely it was developed at St. Jude's. Carpenter Edwards porcine valve. So what's a porcine from? Or is it porcine? Is that
Isn't that from pigs?
Is that right? Is it pigs or is it cows? I'm not a
I
Texas.
thought bovine was cows.
Bovine, that's right. They make them out of bovine too. So there's a bovine valve and then the porcine. I always want to say porcupine and I always confuse it between
I know, it makes me
cow.
think of that.
Yes. So yes, it's pig for the porcine and then the bovine, and they have bovine ones too. All right. And then the transcatheter aortic valve. So what is this one over here? What does that look like to you guys? What have you seen that we talked about where we put a catheter in and we blow up the balloon and then we deploy this?
Like a stent?
This one looks like just a big version of a stent. Okay. So that's the transcatheter aortic valve. Okay. So good. All right. So I'm kind of pulling back and forth from that other one. All right. So when we're doing that valvoplasty, if a patient's getting that, because lots of patients are getting these procedures. If you guys were up on 9 West and some of you guys are going to 9 West this weekend or this week, they will a lot of times get those cardiac patients up there. So on 9 West, and I want to describe this because this is kind of typical that you'll see it at the hospitals, is you're going to see a floor where they have a cardiac floor, like 9 West is the cardiac, right? And they have a clean side and a dirty side. So what do you guys think? Why would we have a clean side and a dirty side, do you guys think, that we call that? The nurses call it. It's not really clean and dirty. It's the type of patients we have up there. Anybody know what we would do with a clean and a dirty side? So the clean side is where the cardiac surgery. So if we're taking them down to get bypass surgery, you know, where we can't open up those coronary arteries and they need the bypasses done, or they need some kind of heart surgery because they've had an MI, or depending on what else going on, we put that on the clean side. And then the dirty side is not, the patients aren't really dirty. They just are patients who maybe came in with an AFib or have some kind of maybe infection going on. So you're gonna keep those clean, you know, those surgical patients away from those other patients coming in, and that's kind of how they split that floor. Okay. And that's pretty typical what you'll see. Now, a bunch of those patients, or especially the one side where the patients are coming in with an AFib, they a lot of times will get up to the floor and then have to go down to the cath lab. Okay. So a lot of those patients, it's nice if you guys get there next semester where you can go down and see some of these procedures. Okay. All right. So with the balloon valvoplasty, we want to monitor for heart failure and emboli. All right. We're worrying about those blood clots. We want to assess heart sounds every 4 hours, and we're going to talk about how we're going to do that. And then same care as after cardiac catheterization. All right, when they have the balloon valvoplasty. So when they go down to get this balloon valvoplasty done, they're a lot of times going to go to the cath lab to do that. So this is one of the procedures. So they'll put in pacemakers down there. They'll open up those coronary arteries, and they're also going to do this balloon valvoplasty if they needed those valves fixed. Surgical valvoplasty or valve replacements focus on hemodynamic stability and recovery from anesthesia. So we might be floating one of those Swan-Ganz catheters in when we're reading those pressures off for that patient, because we want to make sure that that patient's stable and we can monitor that closely. So those patients might go from 9 West, go down to the heart cath to get maybe this surgical valvoplasty, and maybe it didn't go as well as they thought they wanted it to. So where do you guys think, if they want them closely monitored, where they're getting vital signs every hour or every even 15 minutes right after the procedure, and we want to make sure they're hemodynamically stable, where would we put those patients? Where do you?
ICU.
They can go to the PACU and then they'll go to the ICU. Yeah, and a lot of times those patients won't even stay in the PACU because the ICU can monitor those patients just as closely as the PACU can, right? So in ICU, you're going to have 1 to 2 patients in the ICU. And a lot of times, if they come right out of surgery, the nurse is usually going to be in that room for at least the first couple hours to monitor that, right? Good. So frequent assessment with attention to neurologic, respiratory, and cardiovascular. So we're going to make sure that those our brain, our heart, and our lungs are being assessed frequently, and we want to make sure there's no changes with that, right? Because we want to make sure they have good perfusion to what we consider our main organs, our lungs, our heart, and our brain. All right. Patient education. We're going to thin that blood, right, to get those. We have these new valves in there, anticoagulation therapy, prevention of infective endocarditis. So we're going to talk about infective endocarditis, follow up, and then repeat echocardiograms, right? So we're going to do that picture. We're going to take that sonogram and see how those valves are working, right, after we've replaced those. So that makes sense that we would do an echo. All right, with cardiomyopathy, so there's all different types of cardiomyopathy. It's a series of progressive events that culminates in an impaired cardiac output, but it can lead to heart failure again, sudden death, or dysrhythmias. All right, so there's different types here, and we're gonna go through those, and you'll see them abbreviated. So when you guys are looking at the diagnosis, the medical diagnosis, you could see cardiomyopathy, but you'll see a DCM, so like a dilated cardiomyopathy. So it gives you a little more specification of exactly what's going on with their heart when they do their medical diagnosis with a hypertrophic cardiomyopathy or a restrictive and constrictive one. So there's all these different types. So you'll see here, it's going to show you what's happening. So this is the dilated, where we talked about that kind of stretch, or that preload gets stretched out. There's the hypertrophic, where that muscle gets so thick. And then there's the restrictive, where it's not pumping out or doing it like it should, where it's restricted in some way due to maybe that thickened muscle, and other things that are going on possibly with the valves or whatever's leading to this. Okay. All right. What is the main electrolyte involved in cardiomyopathy? What do you guys think of these 4 choices? Which one do you guys think? Let's see what you guys think.
Yeah, potassium.
C. C. See what everyone says. See, everyone's thinking it's potassium, right? Let me see. And so, okay. All right, it actually is the sodium. So number D. So it's the major electrolyte involved in the cardiomyopathy. Cardiomyopathy often leads to heart failure, which develops in part from the fluid overload. And the fluid overload is often associated with elevated sodium levels. So what happens with salt? What does salt do? Does it let go of water, or does it retain water? What do you guys think it does? Yeah, so it retains water, so that holds on to the water. And that's why when people are, there's a lot of contradiction or a lot of talk about sodium and dehydration and everything, but it will hold on to that water when you have that sodium. Okay. All right. So what we're going to do nursing process wise for cardiomyopathy is we're going to talk to them about their history. If anyone's had any issues, predisposing factors, if they're having chest pain with it, and then we're going to review their symptoms. So we're going to look for that orthopnea or that syncope. We're going to review their diet. If they're on a lot of heart patients, congestive heart failure, cardiomyopathy, we want to try to reduce that sodium and do some vitamin supplements. What are different salt diet restrictions that you guys have heard of people talking about with patients when they want to restrict their salt? What are different things that we talk to them about? What food items that it's high in salt?
Usually canned and frozen items have a lot of sodium.
Yeah, lots of canned foods, soups. Do snack foods have lots of salt?
Soda even.
Chips and all that kind of stuff. What condiment has a lot of salt? Yeah, no prepackaged foods. What condiment has a lot of salt that people, yes, it's
Ketchup?
ketchup. Ketchup's a big thing. I remember talking with patients and their biggest part was the ketchup was their big thing. Yeah, soy sauce. All the things that we like to add to food that makes it taste better. Yeah, and fast foods. Good. Yes. So we're going to talk to them about that, how they're doing with their diet. And you can hear whenever I get someone who has syncope, even younger or older, the first thing I talk to them is about what did they eat for the day? What did they eat in their diet? And you can kind of discover pretty quickly when, like, for instance, a 20-year-old only had an energy drink or 2 energy drinks for the day, that we could be having some diet issues with people like this. And then so on, and then the older patients that are having this. Okay. All right, so psychosocial history, impact on family, stressors, depression, where they're at with their well-being. And then we're going to look for vital signs, pulsus paradoxus, where our blood pressure can go down as we're breathing, weight gain, weight loss, PMI, murmurs, S3, S4, pulmonary auscultation of crackles, JVD, and edema. So we're going to look and see what all physical assessment wise is happening with them. All right, so these are some of the diagnosis in relation to that. We know that decreased cardiac output is a big one with our heart. And then tissue perfusion to our heart, our brain, and all the way the rest of our body peripherally. Impaired gas exchange, activity intolerance, anxiety, powerlessness, and then non-compliance with medication and diet therapies, okay? And many reasons for the medications, they can't pay for them, they don't like the side effects of them, so we have to drill down to find out why. All right, so different things we're looking at with this: heart failure again, dysrhythmias, you're going to see both atrial and ventricular, cardiac conduction, pulmonary or cerebral embolism, and then vascular dysfunction, or valvular dysfunction, not vascular. All right. So what we're going to do is we're going to look at maintaining our cardiac output. A lot of times we've had a lot of success with medications. We're going to try to increase their activity tolerance. That's why we look into like our cardiac rehab, pulmonary rehab is a big thing to monitor these patients as they're doing those activities. So we know that the more activity they get, the better they do, but we also have to monitor those patients because they're older and can have issues, and this is a safer way for us to do it, right? Reduce anxiety if they have issues with that. We might have to give them some medicine for that. Adhere to our self-care program, increase sense of power with decision making, so they get to decide what things they're going to do with this, and then we're going to try to get away from the complications that they're having. All right, so what we do with these patients, some interventions. So to improve our cardiac output and peripheral blood flow, we're going to do those rest periods, especially when they're doing activity. We're going to position them with their legs down. We're going to use supplemental oxygen. So we're going to titrate that to a certain level. We're going to do medications, low sodium diet, and then avoid dehydration. So we want to make sure, especially in Texas, that these patients don't get dehydrated. So if they're going, for instance, to watch their grandkids' ball games outside, or we really want to encourage them to make sure if they're doing those activities that they bring water, that they stay hydrated, because that gets them into a bad place. All right, so cycle rest and activity, ensure patient recognizes symptoms that indicates the need for the rest. So if they're doing, they're playing golf, they need to use a cart versus walking it like they've always done, or, so you have to make sure they build that into their activities. And then alleviate their stress, educate them about the diagnosis, and assist with anticipatory grieving, unfortunately. All right, if we look at the, we know the powerlessness, we're not going to assist patients identifying the amount of control they still have left. We talked about that. Educate patients about ways to balance lifestyle and work while accomplishing their therapeutic activities. Okay, so, a lot of people want to work up to however long they want to work. And so you're going to try to help them be able to do that. And then you're going to talk with the family, and you're going to encourage them to take a CPR class and then understand how the use of an AED. Okay. All right. We talked about this with our vitals and then activity. So you guys carrying out daily living, and we'll do that while they're in there, you know, have them brush their own teeth, do all their stuff that they're gonna be able to do at home. All right, same time, this kind of just repeats. All right, let's look at infectious diseases of the heart, okay? So any of the layers of those 3 layers of heart can be affected by this. So, and the diseases are named after the layer of the heart that's affected, okay? So the diagnosis is made by patient's symptoms and an echo. And we're going to manage for all infectious disease prevention as best we can. And then we're going to do IV antibiotics usually are necessary once an infection has developed in the heart, okay? All right, so these are the different types that you'll see. You'll see rheumatoid. Have you guys talked about rheumatic endocarditis with Professor Groth? Did we talk about this at all in the heart section?
I don't believe so, but it's heavily focused on the prep use.
Okay. Yeah. So school-age children, that's why I kind of mentioned that, is the most common that you'll see in rheumatic endocarditis. It's usually the virus that it is that beta hemolytic streptococcal pharyngitis. So it starts off with that throat infection in the mouth. We can swab for it, and we know that this is the one we see the most for the strep, and we need to promptly recognize and treat the strep throat to prevent rheumatic fever. Okay. So, and the kids, and I'm sure she talked about that, they have like abdominal pain. They have some weird symptoms that that happen. I can tell you guys a story my son had when he was like 3. He was not eating well. You can tell and then he is usually very healthy and running around. He's very active, right? And so he wasn't eating well, and I'm like, oh, something's up with him. So we took him in. He got swabbed, and he had strep, right? Strep. So now here, move it up 2 years later, and so he's probably 5 or 6, and he all of a sudden we're in Walmart, and he's bowling over on the floor, and I'm like, oh my gosh, what is wrong with him? Like, you know, this is not what's going on. Like, have to take him out of the store. Well, he has a sickle cell trait. So I was like, oh my God, this is a sickle cell. Even though he has a trait, it's not, he doesn't have the disease, he has the trait. So I was like, oh my God, this is what it is. So this is a very this is why nursing sometimes is not the mother. So I got so upset about it. I called my friend who's a doctor, and she's like, okay, this could be true. So I drove him all the way to Cook's, which is like an hour-and-a-half drive. I was like, we're going right to the hospital. I was a little overkill on that. So then when I get there, they are like, we're in there, and they're like, oh, I was like, he hasn't had a sore throat, da, da, da. Well, she looks in his throat, and she's like, well, it looks a little red. Well, they swab him, and it's strep. And I was like, are you kidding me? So his stomach pain was actually strep. For a little kid, that's a typical sign for that. But that kid's fooled me with strep like a couple times. I'm like, come on. So, all right. So infective endocarditis usually develops in people with prosthetic heart valves or structural heart defects. Also occurs in patients who are IV drug abusers and those with debilitating diseases, indwelling catheters, or prolonged IV therapy. Okay, so now let me see what's next. I have some pictures. I want to show you that. Okay, let's go through the other ones. So pericarditis, inflammation of that pericardium may cause potential complications. So we're looking at pericardial effusion. What was the effusion again? Pericardial effusion. What was effusion? You guys remember the term effusion? It can happen in your knees. It's mostly you'll hear it in your knees or around your heart. Fluid, correct. So effusion is fluid, and cardiac tamponade was that fluid that fills up in that space between the parietal and the visceral between your heart, where we can get to it, where that fluid fills up and your heart's not able to beat, and we're going to have to stick a needle and draw that fluid off of there. And a lot of times it's blood, maybe from a trauma, but we can also get it if we have a bad pericarditis or inflammation of that layer of your heart. And then the myocarditis, the inflammatory process involving the myocardium. Most common pathogens involved tend to be viral, and endocarditis, they tend to be bacterial, and complications, that cardiomyopathy and heart failure that happen. Okay. All right, how we doing, you guys? You hanging in there? All right, so we see fever and high, we see some high fevers. New heart murmur or friction rub in the left lower sternal border, so pericarditis. So you're gonna hear that sandpapery sound when you're listening. With rheumatic, you're gonna see the oscillar nodes, the Janeway lesions, the Ross fonts, and the splinter hemorrhage in your nail beds. Did you guys go through that with Professor Groth at all? Those different rheumatic symptoms? Yes.
Yeah, the
Did you
first.
guys see pictures of them, or did you look at it, see them in your book? I have some good pictures to show you. Okay, no pictures. Okay, I'll show you because I have to see pictures and then I can remember it. Cardiomegalia, heart failure, tachycardia, splenomegalia. Okay, so these are the different manifestations: syncope and palpitations, chest pain, fatigue, and shortness of breath. All of these are gonna kind of help to figure it out, but a lot of things have these symptoms, so we have to kind of rule it out, right, as we go. And then we're gonna do blood cultures. So we're gonna be doing that. When do we need to do the blood cultures? Do we do it before or after we start the antibiotics? So you guys always have to remember we do those blood cultures before. Has anybody been able to do blood cultures or seen a patient get their blood cultures done yet? So it looks like 2, yes, good. Iffy, what does it look like? Annie, what do they look like? If you guys remember. 2 bottles, yep, 2 glass bottles that have liquid through there, and then we put those blood in there to go and send down to the lab to see what's growing there. Usually, how long does a blood culture take before we're going to see results on a blood culture result? How long does it take to grow out that bacteria or virus to tell us what it is? Yeah, 2 to 3 days. Usually about 3 days is pretty typical. And what you'll do is you'll look in your lab. When you're looking at your labs, you can look into the report, into the electronic medical record, and you can click on that blood culture and it'll say report pending, right? So that means they're still growing out whatever that bacteria or virus or whatever the patient has. All right, and then you can see an echo, CBC, the rheumatoid factor, the inflammatory markers. Okay, and then that TEE was when we stick that scope down there and see the backside of the heart going down our esophagus there. All right, so what we're gonna do with these infective endocarditis, these different ones, we're gonna use antibiotic prophylaxis before certain procedures. So that's why the dentist will ask you, have you had infective endocarditis before? Have you had that kind of inflammation? So they might start you on antibiotics. Ongoing oral hygiene when we were talking about the mouth in comparison to the heart. Female patients not advised to use IUDs. We want to take meticulous care should be taken with patients who are at risk or have catheters. So if we don't have to put a catheter in a patient, we try not to if we don't have to, right? Because that's always a source of infection that the patient can have. And then that's the big push. You guys will see at any place, if we have to put like a Foley catheter in or that Swan-Ganz catheter to read pressures, we want to remove them as soon as they're no longer needed. So you'll see that we'll track patients like at a surgery where we only want that catheter in for 24, 48 hours, 72 hours at the most. And then we want to get that out of there. And then immunizations, keep up to date on that. All right, so here's a question. A patient with restrictive cardiomyopathy taking DIG presents with symptoms of anorexia, nausea, vomiting, headache, and malaise. What should the nurse expect to be included in the plan of care for this patient? What do you think we need to do with this patient?
B.
Okay. Yep. Yeah. So you guys make sure we know what our DIG symptoms are of an overdose, which you guys do, it looks like. So we needed to decrease it. Patients with restrictive cardiomyopathy are sensitive to digitalis. Nurses must closely monitor these patients for dig toxicity, which is evidenced by those different symptoms. They want to avoid nifedipine, and they do not need to be admitted to the ICU. We just have to decrease that dose. All right, I think that was the end there. Okay, let's see. All right, how you guys holding up here? Let's take a break. We're going to go to D2L. Okay, so if you guys can pull up D2L, I want to go through those things that I added onto the site into cardiac. I'm going to share my screen and show you guys here the different things I put on there. Okay, if we look at, let's look at, I'm going to see which one I put him in. Let's do this. Let's look at this one first. Okay, so these are some memory sheets that if you guys ever, does anybody have these memory books? You might have bought them in earlier semesters. Did anyone buy either of these type of books? Yes, okay. So these were where I'm pulling from, you guys. So these are memory sheets. They have like acronyms. And so if you guys go to the cardiac part, they have these sheets, and I don't have all of them copied, but I have some of the good ones that I like that'll kind of help you to remember different things about cardiac. So this first one on this sheet is one, and it's a different way to look at the P wave versus the QRX complex, and how that electrical activity with the SA to AV node, the bundle of His, relate to your waves in your EKG. Okay, so there's a memory sheet for that. There's a lead placement one where I talked to you guys about that salt, pepper, ketchup, you know, or the hamburger. Here's the STQRS. So I just put them on there in case you didn't have this book, and it gives you what signs and symptoms to look for an MI, coronary occlusion, or a heart attack. Same thing. We know our MONA, that we need morphine, oxygen, nitro, and aspirin. And that's a lot of times when a patient comes in with chest pain into the ER, that's the first 4 things we're going to do for them. Okay. And sometimes you'll hear them talking about NONA, like they reverse the order, but I'm okay with this one because you're going to do all 4 of them kind of at the same time. You're going to be giving them all to them. There's another one where cardioversion versus defibrillation. And it talks about the joules, and I'm going to go through an algorithm with you guys and to show you guys how that'll work. Okay, so that's that first packet. Of course, the thing that I was thinking was in there wasn't that one. So let's go back. Let's look at, that was that one. Let's look at cardiac measures here. I'm looking for it. Okay, so here's the second one. So here's some more of the sheets where we have cardiac output, which is our heart rate times our stroke volume equals our cardiac output, because we're always going to want to know what that patient's cardiac output is, right? If they're having heart issues. Here's another picture for preload and afterload to explain that stretch and that contraction that happens, and that resistance for the afterload that heart has to go against. This is the one I wanted to show you guys here. So ape to man. When you guys are listening to the heart on any of your patients this week, I want you guys to do the ape to man. So if you're listening up in this second intercostal space where we're putting that V1 and V2, you're going to hear the A is going to, which valve is the A talking about? So we're going to listen up in this space, and we're going to be listening to the best valve to hear when we listen in that A spot is which one? So let me grab my stethoscope. If you guys have your stethoscopes, you can grab those. So you're going to hear your aortic. So you're going to put that over on, am I doing it right? I got to flip myself. You're going to, so that's where you're going to hear the aortic valve the best. Okay. And then straight across where you put your V2 is going to be the best place to hear your pulmonic. So if we know we have an aortic valve replacement, where are we going to go? We're going to go at that second intercostal space right there. And that's going to be the best place to hear that aortic valve. Okay. Let me see. I don't hear you guys talking. Okay. And then you're going to do, and that's that mnemonic that they're talking about. So if you guys look on this sheet, aortic pulmonic, tricuspid, and mitral. And these are showing the places. So when you guys are doing that with a patient or in simulation, you're going to go to those 4 different spots to hear best when those are. And then if you know they're having like a mitral valve prolapse, we're going to go lower, more towards the apex of that heart to listen. Okay, does that make sense? Anybody out there making sense? Okay. All right. Good, good, good. I'm like, everybody asleep? Anybody here with me? All right, here's LDL, HDL. So we talk about those where we want to lower our bad cholesterol, increase our high. So above 35, and these numbers change occasionally, where like sometimes the high is they want it higher than 40, and we'll encourage and watch people. All right, this is another, and you guys can flip this. This is another handout that's going to talk about that ejection fraction. Let me see if I can flip this. Can I flip this while I'm talking to you guys? Let's see. No, that's just going from higher to lower. Do you guys know how to flip this from here? Because I'm so good with the computer. All right. So basically what we're talking about is this ejection fraction compares the amount of blood in the heart to the amount of blood pumped out, right? So the fraction or percentage helps describe how well the heart is pumping blood to the body. So here is showing you our normal ejection fraction is 50 to 70%, because we said that not all the blood is pumped out of our heart every time the heart beats. So our normal is 50 to 70. Borderline ejection fraction is 41 to 49 is pumped out during each contraction. Symptoms may become noticeable during activity. So when this guy's walking his dog, he's going to start getting short of breath. And then reduced ejection fraction is when we're less than or equal to 40% is pumped out. And during each contraction, symptoms may become noticeable even during rest. Okay, so this is when you're looking at heart health for a patient and you know that they've got an echo done or they went to the heart cath. And at the very end, when we push a large amount of dye to see how well that part is pumping out, we will do that ejection fraction. And I don't know if you guys remember me telling you that that's like, if I have a man on the table, that's when I tell him, okay, this is going to be the closest you're going to feel to a hot flash that women will have later in life, that where that dye is going to give them that hot sensation all the way down their body, because it's going to be that it's showing what their ejection fraction is. And we're going to be measuring that with dye that we put into their heart. Okay. All right. And then the last one is just a blank page. So those are those handouts that I talked about that I wanted you to see for that. All right. And so those are those two. All right, let's look at heart blocks. So where are we out of time? Okay, I think we can get through this and then we'll take a little break. All right, so let's look at this. Let's see, I'll download this here so it's easier for you guys to see. So the first one is the first degree. So when we talk about heart blocks, we know that there's a delay of some sort in the conduction from that SA to AV down both sides of the left ventricle or the ventricles. So let's see, here we go. All right. Okay, so here is, can you guys still see my screen? Yes, okay, good.
Yeah, I can see it.
All right, so here is what's happening with this one. So in this first degree heart block, what you're gonna have is, you're gonna have a prolonged PR interval there, okay? So what did we say our normal PR interval was? Do you guys remember? What were the numbers I remember? It is 12 to 20. So 0.12 to 20. Good, good. So with this first degree, you're going to be in a first degree if that PR is greater than the 0.2, which is the max of that, or that 20. Okay. So let's see if we go here. All right. So these are the different types. We're going to, I jump right into it. Let me get out of this. This isn't helping with this. Sorry, guys. Let me close out of there. I think if I just do that, it'll be easier. Let me just zoom it up here. Okay, So with that PR1, and I've got notes under here, so if you guys forget, this type of AB block in which every impulse is conducted to the ventricles, but the duration of the AB conduction is prolonged, okay? So it's greater than that 0.20 seconds, all right? So the P wave is normal, the QRS is normal, we just have a longer PR interval greater than that 0.20 for the first degree block, all right? And that's the least, that's the best of a blocks, that's the best one you wanna have, okay? These are the we know there's a first degree, there's 2 second degrees, and 1 third degree. The reasons that we have these, or the patient can have these a lot of times, it can be caused by heart disease, an MI, digitalis toxicity, electrolyte imbalance, or an infection, okay? So there's a bunch of different things that could be causing this. If the cardiac output is decreased, that we can consider putting a pacemaker in this patient, okay? All right, here's another first degree block. Now our QRS looks different, probably because of some heart disease that this patient has. But when we measure that PR interval, it's still greater than that 0.20, okay? And that 0.20, how many big boxes is that from dark to dark line?
1.
Correct, 1, right? So here we see 2. We can just look at that quickly and see that we started our P, and then the beginning of our QRS, there's 2 boxes there. So we already know that that's a first degree, that it's just that longer duration, okay? All right, now the second degree, type 1, is when the interval goes, it's larger than the 0.20, but it increases. So this one is going from 0.24 seconds to 0.32 seconds. So there increases in each time. And then what happens is you have a blocked QRS. So it drops the QRS, the P wave's still there, and then it starts up again. So then it'll start usually at the 0.24, 0.32, and it's going to get longer. You know, the PR is going to be wider each time, and then it drops a beat. Okay, so you can see where that lost this QRS again here after the third beat. That's a type 1. Okay, now the second degree type 2 is where we have, let me see if I can show you guys, where the it's a longer PR interval, but it drops a beat and it doesn't increase in those intervals. It's a longer PR interval and that stays consistent, but then it blocks a QRS. So it's blocking like this first degree, but this one did it where the prolonged QRS got bigger and bigger. This one keeps just that prolonged, keeps the same length each time, and then drops the beat. So the one is, it stretches it out, and the other one, it's bigger, but it just drops a beat. Okay, does that make sense? Good, okay. And you can see that. And then the third degree is when what's happening with this is there's a total block between the atrium and the ventricles. So the P are doing their own thing, and then the QRS are doing their own thing, okay? Because there's a total block. So they're not firing. They look like they could be firing at the same time. Like this looks like maybe this is a P and then the QRS. But once you look at it, there's not a QRS with every P. And if you mark them out, like if you take your paper or you take your EKG measurement tool or the computer does for it, if we mark P to P and we go across, it's going to be in a consistent P mark where it's got its own pattern, and then the QRS have their own patterns. So even though it looks like it's firing close to the P, then later this first beat, it's not really firing close to that P at all. So they're blocked where the one side is firing and then the other side is firing. Okay. So I had a gentleman who came in and he was in a second degree right off the bat. So he was in a second degree type 2. So he was this type, and he had been playing softball. So a lot of times you'll see patients where they're doing activities and then they start throwing themselves into these rhythms. So he came up to the ICU when I was overseas. He was in a second degree. He was talking to us and we were all watching him in the second degree. Then he went into the third degree, right? So we're watching this and we're trying to get medication on board. And then all of a sudden, what do you guys think to him? He was sitting talking to us, playing softball, really nice, funny guy, young. He was in his 40s. What do you think happened to him?
He died.
No, he didn't die. What do you think happened to him first? Or he didn't die. I should say what happened to him first. He passed out on us, right? So we were calling, because what's happening, what kind of perfusion is happening to the rest of his body? His heart was able to maintain it because he was a young, healthy guy. But when you go into these blocks, when your atrium's firing separate from your ventricle, you're not going to get that perfusion out like you need to, and you're not going to last too long. So we were kind of all like, oh my gosh, this is crazy that this guy's, talking to us, and then he passed out. But he did fine once we got the medication on board, got his heart into a regular rhythm. Okay. All right. You guys ready to take a break? And we'll go back. We're going to look at aneurysms here real quick, and then we'll go back onto the chapters. You guys want to take 5-10 minutes? What does everybody need? Everyone get up, stretch. 10. Okay, let's do 10 minutes. So we'll go to till 2:10, 20. yeah, 2 hours. I know, we're getting there, you guys. I know, this is like so cool stuff. Like, and then when you go into clinic, you're like, oh, I totally know what's happening. I totally know how to read this EKG. I totally know what to do. We're in trouble right now. Team vote. Okay, team vote. We'll just do 10. We'll do 10 minutes. Let's do 10 minutes. That's good enough. All right, so we'll see you back at 2:10. That's almost like 14 because that's only 1:56. And then we're going to go into aneurysms here. Okay. Got another minute. I'm going to share the screen. We're going to look at infective endocarditis. I want to show you guys a couple pictures. So give everyone a minute to get back. All right, we're at 2:10. So if we look at this, you guys, so I'm going to show you with the infective endocarditis, right? They claim there's about 10,000 to 15,000 new cases diagnosed in the United States. The therapy for this is antibiotic treatment, but it's usually a long antibiotic treatment. So we talked about the different layers, and then here's the different ways we can get that infective endocarditis. So here's some what we call it is vegetation. Now, the thing I like you to point out in this picture too is when we take a picture like of a wound or something like this where we're showing the vegetation that's growing on these valves and in this heart, they use a ruler because nurses are not photographers. No, sometimes they are, but you want to use a ruler so we can, if someone zooms in or zooms out, because a lot of time if someone comes into the into your facility with a wound, we always want to get a picture when it comes in. Sometimes they'll take daily pictures as it's, you know, the wound clinic will do that, and then before they get discharged. Okay, so it's always a good idea, and you'll see that a lot of times we put rulers in the pictures so we know, we can tell the size, right? So this is what, let me see if I can zoom it down a little, what this bacterial endocarditis of a mitral valve looks like. So it looks like vegetation, right? That is happening on these valves. And then you'll see here's a stenosis, mitral valve stenosis with vegetation. So it looks pretty nasty. Do you think that because the heart is a big muscle, right, that pumps really forcefully, do you think fighting an infection in the inside, for instance, if we have it on the inside layer, is easy to do with antibiotics? Do you think it would be harder or easier?
Harder.
Right, right. Let me see, my chat boxes went away again. I hate when that does that. Okay, let me stop this row. I'm going to stop the share for a minute. And I'm going to put it back on. I can see it there. I hate when I share it and I can't see it. Okay. Yeah, so it's harder. So they need a lot more therapy wise. There we go. I got it back. It's on D2L. You have to download it from D2L. Are you guys talking about the slides, these slides? Okay. So I just wanted to take this to see the pictures. Okay. And I can pull those pictures. I was trying to incorporate it in, but I have so many that it's hard for me that I need to work better. All right. Again, I said, remember, very high fevers, chills, weakness, malaise, fatigue when this is happening. Okay. So these were those clinical manifestations. You're going to, so when a patient comes in, these are some symptoms. If they're running a high fever and we're thinking like an infection and it could be in their heart, we're going to look for these different symptoms. Okay. So the first one is these splintering hemorrhages. So they're non-specific. See, they can see on their fingernails, and you can see that when patients like hit their fingers and they have little bleeding under there. These are what we call splinter hemorrhages. So what's happening is that vegetation's breaking off and causing these issues. So they're non-specific, non-blanching, linear reddish-brown lesions found under the nail beds, usually not the extent of the entire length of the nail. Okay. All right. So these ones are osteolar nodes, where the osteolar nodes on the toe pad of the fourth, right there, you can see that one, of the fourth toe. Note the multiple petechiae on the foot. And on the right, the osteolar nodes on the anterior surface of the distal phalange of the long finger, the purplish area was tender to palpitation. So to remember the difference between these osteolar nodes and these Janeway, so the left is Janeway lesion on the hypothenar eminence, also noted smaller Janeway lesion on the base of the long toe. So they look kind of similar where they're round. The osteolar nodes are painful. So remember, like they hurt. That's like painful. And then the Janeway lesions are not. Okay, that's the difference. One are painful, the other one is not. But they're going to be little hemorrhaging, little bruising that you see on the palms and the fingertips. So you're going to be looking for those. Okay. All right. So now if you look at the other thing is you're going to see Roth spots. So when we look in the eye, like if I take, has anybody seen a picture where they hit the red reflex in your eye and the person's eyes look red? This is like older camera days, right? Where they can see where they look like the devil, where they have red. So what's happening is that light, that camera light is flashing through that pupil and it's going to look in the back. And when you guys go for an eye exam, they're looking back in there to look at this eye retina. So your arteries are back there giving, nourishment to your eye. So this is what a healthy, when they're shining that light in, and you can take, you guys, if you are like say in an exam room, you can try to practice with that and see if you can see the eye retina with that. And when we're taking those pictures with those cameras, it just happened to shine the light in where it's hitting that back side of the eye where we can see this eye retina. Now this is what Ross spots. So this is what a healthy eye retina is looking at. And this is what the people, I have a friend who found cancer through an exam. Yeah. So yes, and that happens. So, but look at, this is what Roth spots look like. So this is a healthy one. And this is splintering hemorrhages in your eye that they will see. And these are Roth spots. Okay. All right. And then you'll see these new or worsening systolic murmurs in patients. You can see heart failure and then manifestations secondary to emboli. So what I want to show you though is what kind of, if we're going to give antibiotic therapy to a patient and say it's going to be maybe 6 weeks, 2-3 months, what is a good way? What type of IV are we going to put in a patient who has an infective endocarditis? What type of line would you guys think? Yes, a PICC line. So we want to put that line that it's going to be more central, dropping out maybe in that superior vena cava where it's going to be mixing with the blood closer to our heart. It's not going to be blowing our vein. We're not going to have to change it out. You're going to be putting a PICC. Now, when we first put PICCs in, they would last for, we were so happy because it was a PICC that they could keep for 30 days. And now how long can people keep PICCs for now? Anybody know? They can keep them up to like a year, sometimes a year, depending on how good, they have a capability to keep them up to a year, sometimes a year and a half, depends. When you have, if you ever start getting where you're doing PICC line changes, always make sure, ask the patient, okay, when did you get this PICC put in? How long has it been in for and stuff? So they try to be really good with that. And you'll see a lot of times when a patient has a PICC line, they're going to come in for a weekly dressing change on the, to get that dressing changed. A lot of times we put a little circular antibiotic disc around where the site is right there that kind of fits like a dressing around it, but a little circular disc, and it has antibiotic in it, and we do a dressing. And a lot of times I think it's just to follow up on that patient. I think the dressing sometimes needs to be changed, sometimes it doesn't, but it is a good check for us if a patient's got something like this that we need to follow up on. Okay, did those pictures help? Does that help? Yes, no, maybe so. All right.
Yeah, our pictures help a lot.
Okay, good. Okay. All right, let's go on to, I think we could probably get both of these chapters in. We'll see how we go. Let's go to, we're going to jump back to this one.
Hey, Professor, can you upload your version? Because the one on D2L only has like 16 slides, and I saw yours had a lot more on it.
Yeah, like I didn't put all those. I was just kind of back and forth. Do you guys want just the pictures, or do you, I mean, I hate to give you guys, there's a lot of stuff in there, so I didn't want to overload you guys. It's bad enough that, but I can put it on there if you guys want to, and you can pull out the stuff you want to. Some people like to see it so they can review for those. So those were, if I'm jumping back and forth to slides, those are slides that was from an Elsevier book. So I try to stick away from it because now we're using Lippincott. So, but I haven't switched a bunch of those pictures over yet, but I like to show you the pictures to see. So I can upload that if you guys want to. I can just put it in a separate category called like Elsevier ones, or I can just cut the pictures out of there if it's going to be on the no. No, so the stuff I'm telling you guys is going to be on the test. I just like you guys to see pictures if you're like a visual person. So okay, so it's pretty much the same information. I mean, it is the same information. I'm not going to throw anything that isn't that you haven't gotten from the lecture, that I more focus on your book chapters. Okay, all right. Okay, let's go to Top Hat here. And we're gonna do chapter 29, okay? So I'm gonna reassign this one. I'll reassign that for review. Make sure to do that for you guys. Okay, so that should be lit back up. And then we're gonna look at 29 here. Okay, so this one's gonna be heart failure. And you guys have heard of heart failure. So chapter 29. Complications from heart disease. All right, so heart failure is considered a clinical syndrome now. All right, so basically it's the inability, if you guys see that last line on that first one, the ability of the ventricles to fill or eject blood is happening, and it can result from structural or functional disorders. We used to, in the past, you would hear CHF all the time, congestive heart failure, because a bunch of the patients that were coming in, that's what they were coming in for, was a congestive heart failure. So these people were having that pulmonary or peripheral congestion with the edema that we could hear when they came in. But they've taken the C part off, and so we just call it heart failure, and it's recognized as a clinical syndrome characterized by signs and symptoms of fluid overload or inadequate tissue perfusion, okay, to the rest of the body. So we've taken that off and not assume it was congestive, but a lot of times that's what patients come in with. So with that term, we know it can be the problem of the heart contracting, which is that systolic failure, or the filling, which is that diastolic failure. And then a lot of cases, we're going to reverse it, and it just depends on what's causing it. And most are heart failure is chronic, progressive condition managed with lifestyle changes and medications. So our medications have gotten so good that we are able to effectively manage it much better than we ever have in the past. Okay. All right. So as your age increases, there's more incidence of it. We say we have 6 million people in the United States that have heart failure, and 870,000 new cases are diagnosed each year. So, and it's the most common for people over the age of 75. And it's the most, what you guys want to remember, it's the most common reason for hospitalization for people over 65. And it's the second most common reason for patients coming into the hospital, into the physician's office. Okay. And they say the big thing you're going to hear about heart failure is they're trying to not get, there was a standard, like a gold star standard, when hospitals, they were penalizing, and I still think they might be still doing some of this, where if the patient with heart failure is readmitted within 30 days of their last hospital admission, that the hospital got money taken back from that. So it's a big push to get these patients under control, put them into a home monitoring where we weigh them from afar, we do their vital signs, and we monitor them. So there's a lot of nurses that are doing that, where they're in, along with diabetes management, there's hypertension management, and then there's congestive heart failure management. So heart failure patients that we're working with. Do you guys know how many million people, if we have 6 million people in the United States with this, how many people as of 2019 do we have in America? Anybody know around what the number is?
Of people with heart failure?
So we know there's 6 million people in the United States with heart failure right currently, but how many people totally? If there's 6 million, how many are in the United States? Do you guys know what the number is? Yeah.
1 million.
328.2 million as of the count in 2019. So yes, about 300 million people. All right, this is what you're going to see. It gives you a little patho of what's happening with the heart failure, you're going to see that depending on what's happened with them, if they had a MI, if they have ischemic heart disease, if they have alcohol, cocaine abuse, they're going to have that decreased cardiac output, decreased systemic blood pressure, and then decreased perfusion to their kidneys. Okay, so then it's going to start affecting our other organs, and we're going to have a hard time with this heart failure. Okay. All right, you're gonna see us talk about right side and left-sided heart failure. You guys remember hearing about that? So we know with the left side, the biggest cause of right-sided heart failure is left-sided heart failure, okay? So with the left side, you're gonna see that pulmonary congestion, those crackles. You can hear an S3, which is a ventricular gallop. So you might hear that extra when you're listening to the S1, S2, you could possibly hear with the left-sided an S3. And then dyspnea on exertion. So we were talking about that with that ejection fraction. Low O2 sat, you can have that dry, non-productive cough initially. And then oliguria. What is oliguria? What do you guys remember about oliguria?
Is that where they can only pee a little bit?
Decreased urine output. So they're considering oliguria is urine output less than 400 cc's a day is considered oliguria. All right, and then on the right side, we could have the viscera or peripheral congestion. We could have that JVD that we're going to sit them in bed and look for the neck to see if that fluid's backing up. We can have the dependent edema. So what you're going to think of on the right side, if the right side's backing up, then we're going to start having symptoms where that fluid's going to have to collect somewhere. So it could be in our neck. It could be down with our feet. It could be hematomegalia, ascites, or weight gain. So with both of those, we could have on the left side that congestion's building up and they're retaining water this way. And then we can have that right side where it's backing up to the rest of us in that venous and backing up, and it's going to cause all these different symptoms. All right. So on D2L, I put some other memory sheets to help you guys remember the left-sided, right-sided, and what that patient's going to look like. Okay. All right. Different medications we start off with are we use our ACE first. Okay, so that angiotensin converting enzyme. So it's going to cause that vasodilation, that diuresis, right? We're going to get that fluid off. It's going to decrease that afterload, that resistance that we're trying to match up against. And we're going to monitor for hypotension. So we don't want to bottom them out. We don't want to give them too much of that ACE. We're going to look for hyperkalemia, so that high potassium. And then we're going to look for that altered renal function and then that cough with that. Okay. So our backup, if the ACE isn't working well for them, we might use this angiotensin 2 receptor blockers. It's prescribed as an alternative, and it works similarly as the ACE. And then there's some others we can use. Another alternative is this hydralazine or isosorbide dinitrate. And then the last, so we start with ACE. Then we start with the angiotensin 2, and then we try this hydralazine or the isosorbide, and then we could go to a beta blocker. But we might prescribe this in addition. So similar like the blood pressure, where we're going to kind of start off, well, with that one, we're starting off with a diuretic, and then we look to the ACE, and we worry about that cough. But we're prescribed in addition to the ACE inhibitors, maybe several weeks for the beta blocker to be seen, because it's making that heart pump stronger. But we want to use with caution in patients with asthma. Does anybody know, can anybody remember why we use a beta blocker cautiously with an asthma patient? What would be a side effect for an asthma patient? What would we not want to happen with their airway?
Bronchoconstriction.
Yeah, bronchospasms can happen with the beta blocker. So that's why we do not suppress the respiratory. Yeah, so we don't want them to have a bronchospasm. So that is why we have to use that cautiously if they have asthma on top of this heart failure that they're experiencing. Okay. All right, so we know we use a diuretic to decrease that fluid volume, and then we're going to monitor any kind of patients where we're drawing fluids off and putting, giving fluids, drawing fluids. So if they're dehydrated or rehydrating them, we always are going to look at those electrolytes, right? Because we know what the sodium, the potassium, the calcium, all those do to help with muscle function. And so we want to, that's always something that you guys are going to be looking at is their electrolytes, okay? All right, the DIG improves our contractility, monitors for toxicity, especially if the patient is hypokalemic. And then IV meds we can use for patients for acute decompensated heart failure. So this miralanon is one that we are decreasing preload and afterload, and it can cause hypotension and increased risk of dysrhythmias. A lot of these, you're going to kind of hear the same stuff where we're worrying, we're going to be monitoring our blood pressure all the time. We're going to be looking at our heart, our rhythms, because we're worried about throwing them into some abnormal rhythm, right? And then with the dobutamine, used for patients with left ventricular dysfunction, increases cardiac contractility and renal perfusion. So you're going to hear dobutamine and dopamine are two ones that you're going to hear that they can use to help that heart beat and contract stronger, and helps with the function of the heart. And we're always concerned about our kidneys and make sure those are fine too. So it's going to be like this fine balance to keep all those depending on what medication. And those medications we'll use one which is really popular, and then there'll be one that'll come along and they're like, oh no, the same type of patient, now we're using this type of medication. So you'll hear that, especially in the ICU setting, where they kind of, we'll use one thing for a while and then they'll always, oh, this is causing these patients to have a lot of this particular side effect, like their kidneys aren't doing as well. So now we've switched over to this particular one, and you'll hear that happen quite a bit. And especially as we get new medications. So the things that we want to consider with the older patients are sometimes they don't have the typical signs and symptoms we see. They sometimes will present with just being fatigued, weak, and not really with it, somnolent, where we can't get them to come to, and we're like, what's going on with them? Sometimes they have that decreased renal function, and they're resistant to the diuretics that we give them, and they're more sensitive to the changes of the volume. So you always have to realize that those older patients keep medication on board longer. Sometimes they don't respond as well, or it takes longer with them, and you just have to watch them more carefully as they get older. And then administration of diuretics to older men requires nursing surveillance for bladder distension caused by urethral obstruction from an enlarged prostate gland. So as a patient gets older, that's a lot of times with men, what happens is their prostate gets larger and they aren't able to pee as well as they used to. So we have to make sure that we're not giving them a diuretic, which is going to increase their bladder capacity, and they still can't urinate. So that's a thing that we worry about with men in particular. Okay. All right. What classification of medications play a pivotal role in the management of heart failure caused by systolic dysfunction? Which one did we say? Kind of flip ahead and I don't even, which one do you guys think did we say? Good. 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 All right. Yes. So that ACE inhibitor. Okay. So for the systolic, that's kind of our first line. And then we'll look at those other ones to add as we go. And you guys can see kind of the rationale between that. I won't read through all of them. All right. So what we're going to do with these patients is we're going to focus on that effectiveness of that therapy, the medications that we're using, how the patient is self-managing, sign and symptoms if it increased heart failure, and then emotional and psychological response. That's always health history. And then our physical exam, we're going to be looking for our mental status, our lung sounds, those crackles, wheezes, heart sounds, overload, signs of fluid, our status, and see if we're overloading. Weigh them is important. So when you guys, have you seen them when you're admitting a patient and they will zero out the bed and get ready because they want to get that initial weight when that patient comes on the floor. So what you'll see is a lot of times a hospital will have a protocol for, they want like one fitted sheet, like a mattress pad, a fitted sheet, or not even usually, some places have mattress pads, some don't. Then they'll have the sheet on there, and that's how they'll weigh it, and they'll zero it from there, right? So then every time when they weigh the patient every day and they aren't moving around because they're so short of breath or whatever their situation is, they'll be weighing them using the bed scale on the bed, okay? So they want a really good accurate weight when they come in, and then we'll usually do daily weights on them in the morning, okay? Then we have to do really strict eyes and O's on those kind of patients. You know, sometimes if they want, they'll put that Foley catheter in so they can get that strict eye and O, or we just have to do a good job if they're up to like the bedside cano or up to the bathroom. And then we're going to assess them as they go. All right, so we know that activity intolerance, how they're doing with that. Excess fluid, anxiety is always going to be one of them. Powerlessness, trying to give them as much control, and then teaching the family how we're going to manage this, okay? And then talking with them about therapy that we're, you know, monitoring when they get home. All right, things we're worrying about is that, again, that hypotension, poor perfusion, and then cardiogenic shock. So if our heart isn't pumping like it should, we can go into shock because our heart isn't functioning well. Again, you're going to see the same things: dysrhythmias, thromboemboli, pericardial effusion, and cardiac tamponade, okay? All right, so fatigue, relieving fluid overload symptoms, anxiety. All right, same thing. I swear they're like repeating this over and over. All right, so activity intolerance. What we want to do, we want bed rest. So we want to keep them on bed rest when they have these acute exacerbations. So you'll see sometimes when they'll say they have, you know, we've talked about like if they have like a chronic bronchitis or a chronic heart failure, that we're going to have an acute exacerbation of that chronic symptom, okay? So when you see an AE in front of, you know, heart failure, they're having an acute exacerbation, like they're having an issue right now, but they've had this for a long time, but it's just a lot worse now to the point where we've had to admit them. And what I like to say is like heart failure patients sometimes have like 9 lives, right? Where they come into the hospital and we have to diuretic, give them an ACE and make that heart beat stronger, get the fluid off, and then they can kind of go back to their thing. And you'll see when people are kind of getting sicker and sicker, they come in more often and they need fine tuning more frequently. So, but hopefully if we can get them where they're monitoring themselves at home, that they won't be coming into the hospital as often to have that, because we'll catch it before and we'll increase their Lasix. You know, their primary doctor will take care of it by increasing their doses of medication and helping. And then once it gets better, so say they get sick, or say they get a mild case of COVID, then we can take care of them while they're sick like that, and then kind of go back to their regular regimen. So you'll see that happening a lot. All right, we want to encourage them 30 to 45 minutes of daily exercise, even if that takes them, you know, all day to do. They might split it up into 10 minutes. Exercise training, pacing activities, waiting 2 hours after eating for physical activity. The other thing they want to avoid is that extreme cold, hot, or humid weather, okay? Modify activities to conserve energy, and then positioning by elevating their head of bed. Anybody having trouble breathing, first thing we want to do is set their head of their bed up, and then support them as, you know, until it gets better. All right. So here are overload, daily weight, INO, diuretic, timing of meds. So we might have to do, if they come in and we give them a 9 o'clock, we might do 12 hours, 9 in the morning also, or 7 and 7, 8 and 8. Certain drugs, you'll see they time off the 9 o'clock in the evening, and certain drugs we do by when we start them. Like antibiotics is a lot of times when we start it. And then we look at things like if we go and hang an antibiotic in the morning at 2 in the morning, that's not going to necessarily wake them up, whereas they're having to take pills. Okay. So there's kind of 2 different thought processes when we're giving timeout meds, and you guys will see that while you're working in the hospital and then when you start in practice. All right, fluid intake. Sometimes we do a fluid restriction, and then we give them a low sodium diet for their diet when they are in the hospital. All right, we talked about this. All right, here's another question. What evaluation most illustrates that the patient with heart failure has met outcomes for the nursing diagnosis, activity intolerance related to decreased cardiac output? See what you guys think. B, okay. I had to talk ahead and don't follow this for Both of you guys, all you guys want to go with B? Maintain heart rate, blood pressure, respiratory rate, and pulse oxygen, and heart rate. Stable vita signs shows that they have been able to adjust and plan activities to improve rest and allow their bodies to adjust. Good. Okay, so unfortunately, then, since heart failure is chronic and often a progressive condition, we do have to consider issues related to end of life and when palliative or hospice care should be considered. So what are some things that you guys would have to, what are some of the things you or the social worker will be talking with the patient and the family back about for end of life care? What have we been talking about, that things that we need to consider for end of life care? What are some maybe documents we talked about or different?
An advance directive.
Yep. Advance directive, living will, who's going to make decisions if they can't. So those are the things that you'll hear them most talk about with end of life care, where they would want to be, like if they want to be in the hospital if something happens, or do they want to be at home? Or what are you guys going to talk to the family about with this kind of thing? Do we want them to go home, or do we want them to go to a facility? Or so some of those things you would have to talk to the family and the patient about, right? Of, is there someone to take care of this patient if they get real bad? Do they need to go to a facility because you can't, the family can't handle it? It's interesting, especially as you guys are with nurses, because you'll be taking these patients. You're like, oh, if something happens to my family member, I can do that at home. Do you guys think, you guys can see yourself taking care of family members at home? Or do you think that they would be something that you would want to do at a facility? Everyone kind of has their different, we used to joke with my parents. My mom would say, make sure you put me in a really good nursing home. Right. Yeah. And it does. It depends on the situation, who's able to do that, if they have the skill to do that. So these are some talks that you'll have with family members and trying to get them situated, right? Because it used to, yeah, finances. So it used to be where we would not even kind of go into that. We would keep people for months at a time, and that just isn't happening anymore. Like we used to keep people in this, because they're considered more of an acute care where it's less than 30 days, right, for hospital stays. All right, so pulmonary edema, acute event results in left ventricular failure. Blood backs up. We talked about that. And it can cause pulmonary interstitial edema, and we can go hypoxic, and it can be severe. So the different symptoms you're going to see, that restlessness, anxiety, cyanosis, weakness, pulse, lung congestion, decreased level of consciousness, especially with older patients where they just get confused. And then we can see that frothy sputum, right? Maybe frothy and blood tinged, where they're coughing up some blood.
Frothy.
I'll
never forget that term.
You have a patient like that?
No, I just the pink frothy sputum, it always makes me think of like pulmonary congestion and left-sided heart failure.
Okay. All right. So we're going to be monitoring our lung cells, minimize that exertion. We could possibly use a non-rebreather, and then we're going to use diuretics and the nitroglycerin to start off with. All right. Position the patient to promote circulation, position upright with legs dangling, and then reassure patient. So you want to be with them, someone with them, and then monitoring our eyes and nose once we give those medications. All right, cardiogenic shock is life-threatening condition with a high mortality rate. We have a really decreased cardiac output, which they're not getting good tissue perfusion, and it's the initiation of a shock syndrome. And we can see those symptoms of heart failure at first, shock state, and then hypoxic. So what we want to do is correct that underlying problem reduce the preload afterload to decrease the cardiac workload, improving oxygen, restore, and then a lot of times we're going to be putting them in the ICU and we're going to do those hemodynamic parameters, monitored fluids, and adjust medicines based on assessment. If it gets really bad, you're going to see us put in an intra-aortic balloon pump, okay? And I'm going to show you guys a picture of that. So what happens is we're going to float that pump, another kind of type of catheter that we're going to do where we are putting that back a lot of times through the femoral artery up to the heart. They're going to come right before, usually it's in the descending part of the aorta. So while it's pumping, it's going to go, it is going to let the heart normally pump in the systolic state, but in the diastolic resting state, it's going to blow the balloon pump up so it will have more pressure to help that blood, you know, maintain the heart circulation part. So I'll show you guys a picture of that. All right, thromboembolisms we're worried about. So we're going to be doing medications to help with that, the unfractionated heparin, and all the different new ones that we have. Xarelto is a big one that you'll hear them use a lot. So
What is unfractionated heparin?
So it's just a type of heparin where they've taken out part of the actual one. So you'll hear them talk about unfractionated heparin, low molecular weight heparin. So there are two different types. I'll have to look that up, double check it, but it's just a different type of it.
That's
but
okay.
I'll look it up. I don't know that I can tell you exactly what that is. But there's another trick I want to show you guys. Do you guys know the rules of 10 for Coumadin and heparin? Of which lab matches with that? Have you heard of that before?
I don't know about the rule of 10.
Okay,
But
I'll show you that. I think I added it to show you guys too. All right, so pulmonary embolism. We'll look up embolism in the right pulmonary artery, multiple emboli in the small branches. So we're worried about those going. That cardial effusion we talked about, accumulation in the pericardial sac, cardiac tamponade. So it's giving you guys a definition of this. Okay, I'm showing you those different, kind of telling you what happens with those. Here's the assessment you're going to see with that cardiac tamponade. So pericardial compression due to fluid-filled pericardial sac, dyspnea, tachypnea, hypotension, paradoxical pulses, prominent neck veins, and then chest pain. And you can hear distant heart sounds. So falling arterial pressure, rising venous pressure for that. Okay. So we're going to have to do that pericardiocentesis to pull that fluid off of there. And then you could possibly do this pericardiotomy where they're going to do a portion of that to excise it to let that fluid, because they think that fluid's going to keep draining there. So instead of just using the needle to draw it off, they're going to open a little window so then it can keep draining from there. All right. All right, so we know this is going into cardiac sudden death or cardiac arrest. We know our ABCs. So for here, they're doing airway, breathing, circulation. And when you do your ACLS protocol then, so you've done CPR, and then a lot of times they're going to encourage you to do ACLS. That's when we include the defibrillation for VTAC and VFib. So we know with those AEDs, those are the two lethal rhythm, the VTAC and the VFib, that we're going to shock for. Okay. All right, what's the most reliable sign of cardiac arrest in an adult and a child? What do you guys think it is? Good, good, good. Yep, absence of the carotid pulse. So most reliable sign of cardiac arrest is the absence of a pulse. In an adult or child, the carotid pulse is assessed. In an infant, the brachial pulse is assessed. Good. All right, so that's a good segue. Where are we at time-wise? Okay, let's look at this before we start the last one. I want you guys to go back to D2L, back into the cardiac part that I put on there. and I want to explain something to you guys. So this is an article, and I picked this article because it is, look at the ACLS algorithm, okay? So I want to kind of explain to you guys how this works. So if you guys can pull that up. This is an article, and you don't necessarily have to read the article. I just wanted to show you the algorithm in it because I can see it really well in here. And some of the other handouts that I have, you can't see it as well. So let me see if I have the book to show you guys. I might not have it. I might have it at home. Okay. Let's see. It's talking about the different medications we use here. All right, if you guys slide down, don't worry about the whole article, but this is the picture I want you guys to see, okay? So if you guys go to page 5, if you guys go in, you are going to see, if you were working in the emergency room, and hopefully maybe you guys might get there 5th semester, if you haven't already gotten there, you're going to see that you might see big posters on the wall. So these are what we call the cardiac algorithms. You're also going to see these on the crash carts. So there's going to be a notebook where you're going to have, if there's different positions when a person's coming in and they've coded, okay, that we get assigned as nurses. So you're going to have the head person, more than likely the physician, that's going to be leading the code. And then you'll have a nurse that'll be running the defibrillator. You'll have a nurse that's recording or keeping notes. You'll have a nurse that is pushing medications, starting the IV, pushing medications. A lot of times respiratory is going to be up at the head and possibly intubating them if they need to be intubated, or bagging them with that ambu bag that I've been showing you guys in simulation. So what happens is, what we're going to do is we're going to follow this. You'll see big posters like in Jacksboro. I think in the emergency room, in their trauma room, they have these. Have you guys noticed in Jacksboro that they have their algorithms on the wall in the ER in a big blow up? Yep. Have you seen those in the emergency room at United Regional, for anybody who's been there? I think they have them. But you can also have them on a cart, on the cart in a notebook, okay? On a clipboard and notebook with your sheet that you're going to be writing down what's happening in the code. So to follow this, what you're going to do, it's just a step-by-step. And in leadership, right, we talked about these algorithms and these decision-making tools, and this is one of them, okay? This is a real one that we use. They update it about every couple of years. So this one is the latest one in 2020. So we're going to start our CPR, and we're going to give oxygen, okay? And we're going to attach the monitor defibrillator. Now we're going to look to see if it's a shockable rhythm. Is the rhythm shockable? So how are we going to know? First, we have to identify the rhythm, right? So we look here and we have VFib or pulseless VTAC. So we're going to be filling for that pulse that we just talked about. Or on this side, so if it's a shockable rhythm, VFib, VTAC, pulseless VTAC, or is it not a shockable rhythm? So they're not shockable rhythms. Are they asystole, right? Where is the heart beating in asystole or no? What's happening in asystole, right? The heart's not beating. And then PEA, what's the PEA again? What does that stand for? Just have you guys type it in. What's PEA? Let's see if anyone can come up with what's PEA. Pulseless what? Electrical activity. Remember, pulseless electrical activity. So there's no pulse, but the heart is still charging, right? So we can still see a rhythm, and it can be any rhythm. It could be a normal sinus rhythm, but we don't feel a pulse, but we have electrical activity of some sort. And we said that heart can stay charged even when it's out of your body. It can stay charged for a minute or two, and but you're not gonna feel any pulse, okay? So if we had that patient and we put them on the monitor and they're in VFib, then we're going to shock them. All right. And you're like, well, how much are we going to shock them at? So if you look over to the right over here, it says shock energy for defibrillation. So for that biphasic monitor, we're going to use, our initial dose is going to be 120 to 200 joules. Okay. If unknown. The second and subsequent dose should be equivalent or higher dose. So a lot of times they'll maybe start off at 120 and they're going to go right to 200 and shoot. Now but with the monophasic, if we have a monophasic machine, we're going to start off at 360. So what was the difference between the biphasic and the monophasic? Do you guys remember with those monitors?
I remember, but I'll let somebody else answer.
Yeah, the way the shot goes, right? So biphasic, it's going to be shooting good, Jared. It's going to be shooting two currents across the heart. The monophasic is only going to be shooting one. So how do we find out if that monitor's biphasic or monophasic? What do we have to look at? And if we put the pad on the front and the back, it's going to shoot through the body, right? So you're going to look at the very top of that monitor. Remember, it's going to tell you, and when we go down to the sim lab and we look at the crash carts, you're going to look at the top of it and it's going to say this is biphasic and monophasic. They've gotten away from most monophasic, but just in case, you have to be able to know what machine you guys are working with. Because when you guys first go, if say you work in the hospital or at a facility, you know, at a rehab place or wherever, the first thing you're going to do is you're going to learn the crash cart. Okay. You're going to learn what's on it. You're going to do a check. Usually they'll either do a 12-hour check on it or they'll do a 24-hour check. All right. So we're shocking them, and depending on our machine, they're going to say dial it up to 120 and you're going to put it on 120 joules. Okay. Then we're going to do, what's our next thing that we're going to do? So we put our leads on, we see we're in a VFib, we shock the patient first, and then what are we going to do? What's the next thing on our little thing here? Now, some of this, because you're having 4 or 5 people in the room running these codes, you're going to be doing it all at the same time, right? So it's going to be getting done all at the same time. So what are we doing next? Yeah, CPR for 2 minutes. And now what are we going to start? What are we trying to start on them? Yes, an IV, or what's the IO? Does anybody know what an IO is? I don't know that we've talked about an IO yet. An IO is an intraosseous. So if we can't get that IV in that patient, and we might not be able to, right? Because they're having such bad cardiac output and their perfusion isn't good and it's hard to stick them, we might stick a IV right into their bone. So we have a little drill, or we used to have like a really forceful needle that we would put in, and a lot of times we would do it in the lower leg, right in the front of that, and we would puncture it, and you would practice. You would take chicken bones, you know, after you ate a chicken leg, and then you would practice putting those IOs into that bone, because you got to go through that bone, and you kind of grate your teeth when you're doing that, right? Now, a lot of times they put these ISOs, if we don't get an IV, they'll put an IO in the lower leg. Now, a lot of times they're putting it in the upper arm here. So why do you guys think they went from moving it from the leg up to the upper arm for a person? Any idea? What is it? Yeah, and what is it closer to? Yeah, it's closer to that heart where we want to get that medication in going to their heart. Good, good, good. Yeah, so we moved from the lower leg, and a lot of times you'll start seeing them putting it in their arm. Okay, now we're going to go and we're going to say, is our shock rhythm shockable still? So we're still in that VFib. So what are we going to do? We're going to shock them again. Okay, so we're going to shock them again. Then what are we going to do next? Yep, CPR for 2 minutes. And then we're going to consider our first medication. So we're going to give, what's the medication we're given? Yep, epi. So you hear epinephrine. And you guys are going to see, when we look at the crash carts, you're going to see that we have these tan boxes that have epinephrine in them, okay? And if you guys look over at the drugs, so look at drug therapy. So how much epinephrine can we give a patient? What's our dosage for the epinephrine? If we look at that middle chart, yes, 1 milligram every 3 to 5 minutes, okay? How many, is there a max dose on epinephrine? No, there isn't. You could see them given 15 doses of that. They're going to go through there and there's no max on that. All right, what's the different routes we can give epi? What does it tell us? What are the different ways we can give it? Yeah, I can enlarge it. And you guys can do this. Let me enlarge it. There we go. If we're looking over here, I'm going to move it to there. So there you can see epinephrine, IV, IO dose, 1 every 3. So I want to take the time just so you guys will be able to, you know, see what they're doing and understand what they're doing. Because once you kind of see how this works, it's pretty easy to follow, right? Because we don't memorize it because we use our, but you kind of start, you'll remember it the many times you have to do it. All right, so then what are we going to consider once we give our epi and now we have 3 minutes to wait and we're kind of still in the VFib? What are we going to be considering at this point? Yeah, we're going to be considering this advanced airway. What's a type of an advanced airway if a patient isn't cognizant, they're in VFib, and what airway? What's the tube that we have to put down? Yeah, an ET tube, the endotracheal tube. Yep. So maybe respiratory is helping us. We're setting up the equipment to help with that. And then what's the capnography? What are we reading with a capnography? How are we going to tell if we're giving them 100% oxygen, say we're bagging them and we're getting all the stuff set up to intubate them? Yeah, that's CO2. So that's going to tell us if we might have 100% oxygen because we're giving them, but the capnography will tell us if they're doing what on their own. What are they breathing out on their own? Yeah, they're CO2, right? And what's our normal CO2 level? If we think about our ABG, what is the CO2 level that these patients should be at? Yes, Esther, good. 35 to 45, yes. 35 to 45. So we'll know if they're at 40 that they're breathing that CO2 off on their own. Okay, so then this is how you guys follow the algorithm, okay? So we're going back to shockable, still shockable. We're going to shock them again. And then we're going to consider amiodarone and lidocaine. And you're going to look over here and you're going to look at what's the first dose? How many milligrams is the first dose of amiodarone? And what's the second dose? Yeah, second dose, third dose. And then we might consider lidocaine. So this is how a code will run where they'll follow this algorithm with anyone in a pulseless VTAC or a VFib, okay? Now, if we look on the other side, and then it'll talk about, here's our quality of CPR. So it's going to talk how fast we want to, 1,000, 2, 1,000, 3. That's for breathing. And then we're going to do 1, 2, 3, 4, 5, 6, 7, 8. And we're going to go all the way up to 30. So it's going to give you instructions for no advanced airway. In the meantime, we're going to be doing compressions 30 to 2. We're going to be looking at our capnography. If it's less than 10, we know they're not blowing it out. So it's giving you CPR instructions. It's giving you shocking instructions for the defib. It's giving you drug therapy there. And it's giving you advanced airway that we want to get that ET tube in, endotracheal intubation or supraglottis advanced airway. So we can put that in to where we open that airway up because we're having an issue putting that ET tube in, which is the ideal. And then return of spontaneous is we know that it's typically greater in between that 35 and 45 range for CO2. So it's giving you all this stuff, okay? So now with an asystole or a PEA, because we have nothing, we do not have a rhythm to shock off of. And like with the PEA, it's just electrical activity. The only thing you can do with that is you have to give IV IO access and you're going to give the epinephrine 35 through every 3 to 5 minutes. And then we're going to do all those same things that we talked about over here, but we're not going to shock them because we don't have anything like with the asystole, we don't have anything to shock off of. With the PEA, we just have electrical activity and we've got to get into a better rhythm to be able to shock them. So you could have a PEA and then all of a sudden get a pulse back and see what they're in. And then, maybe we see a VFib and you'll see patients do that where maybe they're back into a VFib and we can shock them, okay? Now the thing with this is then you're going to look at reversible causes. So while we're coding them, sometimes we're trying to figure out what is happening with this patient, okay? So what we're doing is we're going to look at our H's and our T's. They're going to say, we're going to treat our H's and our T's. So the first H we're going to look at is hypovolemia. When we were running this code, how are we treating our hypovolemia? What would we be doing? What did the nurse put in? And what would we be hanging? Yeah, you're going to be hanging IV fluids, either the normal saline or the lactated ringers, right? And that's what you're going to find in your cart. A lot of times it's on the bottom of that cart, and you're going to be putting up a fluid to go. So you're going to be working on that IV, either IV or IO, and we're going to treat that with the fluids. Hypoxemia. How are we treating the hypoxemia with this patient? Yep, we're giving them O2. We might be intubating them to give them O2. So that's how we're going to treat that. Good. Acidosis. So we have a hydrogen ion. What in our crash cart, or have you guys heard that we treat the acidosis with? Anybody? Yes, bicarb. So we're going to be treating that acidosis with the bicarb. There's my pharmacy and Valerie, where it's a big, when you guys see the bicarb, it's a big ampule that you'll be pushing in to treat the acidosis, okay? Hypo or hyperkalemia. How are we going to know first that we have? What person's going to show up and tell us that we have a hypo or a hyperkalemia with this patient? What ancillary staff can help us to tell us what our, when we start an IV, we could also draw this off to run it to somewhere to tell us, yeah, the lab, right? So the lab, the ABG won't tell us the potassium, right? It's going to tell us the pH, but the electrolyte, when we run an electrolytes, we're going to tell us if we're hypo or hyperkalemia. So we can treat that, right? Hypothermia. How are we going to treat hypothermia with these patients? What do we do if they're hypothermic? Yes, warm heated blankets, bear hugger, some kind of device. So we're going to pack them in blankets, room up the room, lots of warm fluids. We could do the warm fluids also. So we're going to be checking their temperature. And then tension pneumothorax. What are we going to do for a tension pneumo? If we can hear no breath sounds on one side. Now those were the H's and these are the T's. We can put in a chest tube. We can do it with just a needle. Like we tap that needle in that space to get that air off, and then we can place a chest tube. How about the cardiac tamponade? What are we going to do for a cardiac tamponade? Draw off the fluid, right? It's that fluid that's in that space in between those two layers of the heart that needs to get off so that heart can start beating right. Yep. How about toxins? Who's going to tell us if they have any toxins? Yeah. So what they're going to do is they're going to do a drug test, because we're going to run this and see if they've done some kind of, if they have a drug on board, like cocaine or something that's causing this issue. Okay. And then thrombosis, pulmonary or coronary thrombosis. What are we going to be doing for that? First, we're going to have to do some, how can we find out if we actually even have that? We can use TED hose, but this guy's way past the TED hose days. So who's going to tell us if we have thrown some clots, maybe in their pulmonary or their coronary area? Yeah, we could see that if it's a big clot. Yeah, radiology, ultrasound, they're going to be shooting some pictures for us to see if we have PE in place. We're going to look at the D dimer, would be good if that's breaking off clot material. And we're going to be maybe doing an ultrasound to see if we're thrown out. So when they say we're going to treat the H's and the T's, all those things that we do, warming them up, giving them fluids, are going to treat those H's and T's. So if we can't get them out of this, we're going to go through this and they're going to be yelling out, okay, we gave a sodium bicarb for the acidosis. We're going to go through all of those and make sure we have addressed all those to get that patient's heart back into the rhythm that we need them to. Okay. Does that help a little? Do you guys understand kind of how we work with that? Good. Okay, good. I'd like to kind of connect that so you guys can see how that, because ideally every time we do cardiac or we start talking about this, and once you guys kind of work on it in the sim, someone is involved, gets involved in a code. There's always one or two of you that after we kind of go through this, or have actually, I think one of your classmates has already gone through one of them, gets involved with that. Okay. All right. How's everyone doing? Do you guys want another break, or are you okay? 5 minutes maybe, or are you guys good? Yes? Okay, let's take a 5-minute break. So we'll come back at 3:15 5-minute stretch, walk around. Let's get it over with. I think everyone's head's like, ugh. Okay, take 5 minutes. I'll give everyone 5 minutes and I'm going to pull up the other stuff. And then we'll start on that. All right, we're going to go to, let's see, we finished that one. I'm going to reassign it and we're going to go to 30 and we're almost done with that. This is just the peripheral stuff. And then I'll see if there's anything else on D2L that I want you guys to look at. Okay, guys, we're back. I'm just looking up unfractionated heparin. It looks like it is undistilled heparin. I'm trying to find it on here. So if anyone can look it up, let's see. Unfractionated heparin and low molecular weight heparins. Let's see, I'm gonna have to keep looking on it, try to find it. I think it's the concentration of it. Yeah, concentration varies depending on the vial used. Undiluted. All right, I'll keep looking. I'm just gonna see if I can find it real quick. I know there's different types. Okay, how's everyone hanging in there? Okay, let's go back. I'm gonna share. Do you guys see my screen? Let's go back and look at this. Okay, so we know what the vascular system looks like. You guys have studied that. We know what's involved. We know that we have the right side of the heart that pumps blood to the lungs, to the pulmonary circulation. We know the left side pumps it out to the rest of the body. We know we have arteries, arterioles, capillaries, veins, and the lymphatic vessels that carry blood and lymph tissue or lymph fluid. All right, so we know that this does the circulatory need, blood flow, blood pressure, capillary filtration, reabsorption, hemodynamic resistance, and then we know peripheral vascular regulating mechanisms happen with this. All right, so a pump failure can cause problems, alterations in the blood and lymphatic vessels, and then circulatory insufficiency of the extremities. You're going to see here's a diagram to show you the blue and the red. I like to give out, if you guys are in class, we kind of talk about I usually a lot of times will have red and blue balloons, you know, to kind of show the different types of how that's working. Okay. We know as we get older that the walls of our blood vessels change, that we show that we can get slits in there and we can get plaque buildup, and then that can break off and that can cause those thrombi that are getting into our coronary arteries. So we know that affects the transportation of oxygen and nutrients in the tissues. We also said we could have a blockage and then we can get a circulation or a collateral circulation that can develop around that can help if it's been something that's gradual over the years happening where we can fix that as we're going. That collateral circulation can compensate for it. Changes cause vessels to stiffen, and it causes us to have increased peripheral resistance, increased blood flow, impaired blood flow, and then increased left ventricular workload, right? So we're going to look at and see if we have different, where our pain is, where we're having the pain. What we have is something, if you guys remember what intermittent claudication is. Can anyone remember that? Yeah, cardiac is really cool, but it gives me such, and it'll get easier once you guys start seeing patients with it. And I'm going to try to come up and you can look at, for the exercise for leadership, we had 4 case studies, right? And those were all a different type of cardiac. So we'll talk about that in class next week and kind of go through those for prioritization. But yeah, it is just a lot of stuff. But once you guys learn it, it's really good. Yes, muscle pain during exertion. So pain in the legs when walking because of venous pressure. Yes. So what's happening is because they have that narrowing or they have some cholesterol buildup or whatever, or a lot of times you'll see intermittent claudication with smokers. So they don't have good circulation because of that smoking, right? So they're, what will happen is to test them. So say for instance, you have a patient, we'll say it's a female and they're a smoker and I want them to walk in the hall. And when they're walking, all of a sudden they have to stop and they have pain in their legs really bad, right? And so they have to stop and lean against the wall. And then when they rest, what happens with the pain? What do you guys think? Yes, it goes away. It actually goes away. So what they're doing is intermittent claudication, where it's clotting it up, causing pain. And then when they rest and relax and those vessels open up a little more and they relax and put their feet up or hang up and stand there for a minute, it'll go away. Now they start walking again. Does the pain come back? And then when they stop and lean up against the wall, then it goes away again. And that's a sign of intermittent claudication. That's a really good example because you'll see smokers that this is kind of sometimes we'll get up and have them walk and test and see if they have some intermittent claudication. All right. Rest pain, then it can get worse where the pain is at rest. And then we have to assess where that pain is happening. Is it their legs? Is it their chest? Is it their arm? Where is it happening? Okay. So when we do a physical assessment on them, we're going to look at their skin, their cool, pale, pallor, their rubor, their loss of hair, bristle, nails, dry or scaling skin, atrophy, and ulceration. So what kind of, do they have sores on their legs? And then what are their pulses? How are their pulses? And I know when you guys have been doing assessments, you're checking their pulses. So you're going to see they're going to look at the popliteal, they're going to look at the dorsalis pedis and the popliteal and behind. So they're going to look at those different ones. If we can't feel those, what are we going to do? How are we going to, what tool can we use? What device can we use to feel for pulses when we can't feel them? Yeah, we can use that handheld Doppler. And then what are you guys going to do as a nurse? So we're looking at this guy, we're looking at picture B, okay? And he finds, it takes him like 5 minutes, but he finds some weak pulses on there, or he went and got the Doppler and now he can feel it. What are we going to do for our next shift? What are we going to do for the nurses that come on shift to help them not have to spend that 5 or 10 minutes finding his pulses? Yeah, you're going to mark it. You're going to take a little marker. We have a skin markers we can use, and we can mark that and put in X where we can feel those. So then when the next shift comes on and they're doing their assessment, they don't have to spend that time finding it, okay? So you'll see those little X's that we put on the patients just to help the nurses as we are assessing this patient, right? So Doppler ultrasound flow studies is a test we can do. The ankle brachial index, we can look and use that. Exercise testing, there's duplex ultrasonography, CT scanning, angiograph, and MRA instead of MRI. Magnetic resonant angiography, and MRI is the magnetic resonance imaging. And then contrast phlebography, and which is the veins, looking at the veins, and then the lymphoscintigraphy. So you can see that they kind of describe what they're running, what they're looking at basically, which is nice. All right, so continuous wave Doppler ultrasound detects blood flow combined with computation of ankle or arm pressures. This diagnostic technique helps characterize the nature of the peripheral vascular disease. So we're looking to see how bad it is, right? I remember having a patient where I was doing an admission for him, and I was writing down he was getting an amputation because he had necrotic like foot basically. But you'll get these patients where you're like, okay, I remember taking his assessment. I said, well, how long did you smoke for? How long have you been smoking for? And he's like, 3 years. And I look up and I'm like, 3 years? And he's getting his leg amputated. And he's like, okay, 30. So at first you have to kind of what, and then he's like, no, I've been smoking for 30 years. Okay. All right, so with peripheral arterial occlusive disease. So our hallmark symptom is that intermittent claudication, described as an aching, cramping, or inducing fatigue or weakness. So it occurs with some degree of exercise or activity, so just making them walk in the hall. It's relieved with rest. The pain is associated with critical ischemia of the distal extremity and is described as that persistent aching or boring rest pain. It's usually worse at night and it often wakes the patient. Okay, so they will complain of not getting a lot of good sleep, and they just need something. They're exhausted because they just can't get good rest at nighttime. Okay, all right. There's some different drugs we can use for this. So this Trentol, this Plentol. Another ones that they will use is the aspirin, right, that we do with those heart patients, the Plavix or the clopidogrel that we've talked about, which is pretty common with heart disease to keep that blood thin. It's the one that we don't have to go in and draw labs every month, like a Coumadin, if we have to put them on a Coumadin, but the Plavix, we don't have to do that. So when you guys are talking about these pharmacologic, where they're thinning the blood, right? They are working, there's different cascading properties. Do you guys remember seeing where how the blood clots up, and it's different phases of that blood clotting stages. If you guys don't remember that, I can pull that up. But basically, these different medications work at different stages of that clot formation, and that's how they're affecting the platelets not clumping up and forming clots like that, and thinning the blood like that. Okay, and then we have the statins, which you know is that cholesterol medicine. All right, so what we have to do, again, we always have to do our health history. That's why in DocuCare, you guys are practicing doing the health history, asking them their surgeries, their medical, all getting all that detail, right? Because that'll give you a lot of information that you can use to figure out what's going on with them. We're going to look at medications, risk factors, signs and symptoms of arterial insufficiency, caudation and rest pain. So when they're having that pain, color changes, weak or absent pulses, and skin changes and skin breakdown. Okay. We're going to be looking for, you'll see a lot of times if you guys start looking at people's ankles, especially in Texas, it's good. It's actually pretty easy to see because people wear sandals, right? Flip-flops. People love flip-flops, which is not a good thing to wear sometimes when you impale stuff in your feet or if you're a diabetic. So, or what's the other animal that people say you shouldn't be wearing flip-flops in Texas for? Another safety issue.
Snake.
Yeah, snakes, right? Rattlesnakes and all this, because people like to get snake bit on their feet, on their legs, and other places, but that seems to be, they're about to step on those. So that's pretty typical here in this area. So we know our diagnosis are altered peripheral tissue perfusion, chronic pain, risk for impaired skin integrity, and knowledge deficit. I'll just stop. All right, guys, we're almost done with this. Let me turn this thing off. For some reason, it just keeps wanting, I either hit the wrong thing or, okay. All right, so our major goal is to get that arterial blood supply as good as we can to vasodilate. So we might use a medication for that. Prevention of vascular compression, relief of pain, attainment or maintenance of tissue integrity, and then adherence to our self-care program, okay? All right, so exercise and activities, walking, grade isometric exercises. So I'll show you some of those. Note, pulmonary consult primary care provider for prescribing an exercise routine. So a lot of times they have certain ones they want you to do. We're going to do positioning strategies, temperature, effects of heat and cold, because we can see like Raynaud's disease, that can happen. And I think we should have like a slide. Stop smoking is a big one, and then stress reduction. So we're going to do those things to try to help that arterial circulation. We know that they can have the atherosclerosis, that peripheral arterial exclusive disease, and you're going to see different places where we're going to have this arterial disorder. So Raynaud's phenomenon, and we'll talk about that here and see if we have it. All right, so we know what both of these are. I'm not going to go through that because you knows what those, you know, those build up of the plaque, hardening of the arteries. You can see this is happening. We can happen in our heart, in our head. So you'll see when people are having TIAs or strokes, if it's an ischemic stroke, that is what's happening, is those plaques are breaking up and causing that blood not to get to your brain, and your brain has to have blood all the time. So that's why you start, when your brain, when you start having people getting confused, or it's because there's not a lot of extra blood supply to your brain. So that's one of the first mental status changes when something like this is happening, is with a stroke or with your MI and gangrene, especially with an older patient who isn't, shows different signs of that. All right. So there's certain places that like to have these plaque buildups. So you can see different areas down by your heart here, where the aortic arch is, popliteal, left common, iliac. So there's different places, common sites of atherosclerotic obstruction. And so they're showing you those different places on this diagram. All right, we know there's modifiable stuff you can do, and we know there's non-modifiable stuff that can happen. We know we can't change our age and gender, but we can look at different things that we're doing in our life, our lifestyle, right? All right, the nurse is teaching a patient diagnosed with peripheral arterial disease, or PAD, What should be included in the teaching plan? What do you guys think? See? 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 Got the wrong thing over here. All right, let's see. Yep, keeping the lower extremities in a neutral dependent position. Need to be enhanced, right? So we, because of the arteries, we want to get that blood down, right? So we want neutral or dependent position, so we can try to help with that flow. Blood flow to the lower extremities needs to be enhanced. Therefore, the nursing crew is keeping the lower extremities in a neutral or dependent position. In contrast, for patients with venous, the blood return to the heart needs to be enhanced, so the lower extremities are elevated, right? So exercise can be prescribed to aid in the development of collateral circulation, right? We talked about that. And some pain is associated with the PAD. All right, so let's look at these aneurysms. And I think this should be, let me look at the end here. And I'll show you guys a bunch of pictures of this. I haven't been following this at all here. Okay. So we can have an aneurysm where it can be a localized sac. A lot of times you'll see them in the aorta, or we can have a dilatation formed at a weak point in the wall of the artery. And it's caused by its shape or form. Most common forms of aneurysms are saccular or fusiform, and I'm going to show you that. The saccular projects from only one side of the vessel. When the entire arterial segment becomes dilated, a fusiform aneurysm develops. Okay, so here's some pictures. Those are the different layers of your artery there. And then this is what the fusiform or then the saccular ones look like. Okay, sometimes it can get trapped between the layers, and sometimes it can form an outer bulge, or sometimes you'll see them where the fusiform where they're bulging on both sides. Okay. So what we're going to do, we have to, this is a common area where we see them is the ascending aortic aneurysm. Why again would that be a place where you could see an aneurysm where it was bulged and out, where that vessel got weak? Why are you going to have that again? Why would that be a good place to have an aneurysm happen? Is it high pressure there or low pressure there in that area? Yep, pressure. Yep, got some high pressure there. So what you're going to have to do is they're going to have to cut an incision in there, and they're going to put it in aortic graft implant. Okay. So similar to like a stent, but this is kind of like a sleeve, like a polyurethane sleeve that they put in, and then they're going to sew it back. And do you think that fusiform, so they're going to keep that tissue in there, they're going to cut, they're going to go surgically put it kind of like an inner layer in there for you, so the blood will flow into that. It's also even the coronary artery, they're putting it right into that aorta. Do you think that fusiform will shrink back onto that kind of stent opening that they've made, that kind of sock that they put in there? It does. Yeah, it forms back and it'll heal up nicely and close up like that. All right, when we see these aneurysms in people, what do you think we're looking for them, or what happens that we just happen to be doing? Do you think we're doing maybe other tests, or do we just kind of find it out because of their symptoms? What do you think? How do we? Yeah, we're usually running other tests and maybe doing an X-ray, and then we see this big aneurysm that's developed. Yeah, so that's how we repair it, and that can be all along the track of your aorta and when it branches out into your legs there. So we'll look at that. Raynaud's disease is that intermittent arterial vasoocclusion, usually of the fingertips and toes. So it's associated with usually underlying disease such as scleroderma. It's sudden vasoconstriction resulting in a color change, numbness, tingling, and burning pain. And usually they're triggered by cold, and it usually occurs in young women. So Raynaud's is usually young women. It's protected from the cold and other triggers, and we avoid injury to hands and fingers. And there should be some, I don't know if your book has a picture in there. I'll have to look. I thought it did. Let me see. So there was a situation where we had a female that came in, a young female who was working with planes, and she was getting this, where she was getting the numbing, tingling in her fingers, and she was loading cargo in cold conditions. So do you think that this would be a job that she's going to be able to keep maintaining with Raynaud's disease? No. So this is some of the OC health stuff that comes in, that you guys will see when a patient has something that is triggering this disease that they have, which they don't even know. They just think, this young girl just thought her fingers were just getting numb and tingling because it was so cold, but she actually had Raynaud's, where it was her fingers were vasoconstricting and they turned blue, and she went numb and tingling, and it hurt. And then she was out in the cold all the time. And so this isn't going to be a job she's going to be able to keep, right? So, okay, good. All right, venous disorders. So venous thromboembolism, chronic venous insufficiency, post-thrombotic syndrome, leg ulcers, varicose veins. So those fall into that order. So we'll look at what's happening with them. And we might have to, they're having venous stasis. So we're going to try to elevate and get that blood to return back to the heart. Different things we're going to do is we're going to do compression stoppings with them. We can do those pneumatic compression devices, early ambulation with them, sub-Q heparin or low molecular weight heparin, and then lifestyle changes. So we're going to look at weight loss if they're real big, smoking, stopping smoking, and regular exercise, right? Because the exercise is going to help with that circulation to get better. Which patient is at highest risk for venous thromboembolism? What do you guys think? Let's see. What are you guys thinking on that one? Yeah, this one's a little tricky. Okay, between A and B. It's actually B, but now A, why I would say, and we'll see what they say on here. So 25-year-old patient with a central venous catheter in place to treat septicemia. So they've gotten septic because of an infection. Some risk factors for venous thromboembolism include, but are not limited to, age older than 65, patient undergoing surgery, central venous catheter placement, septicemia, and pregnancy. So they're throwing in all of those, but this one had a central venous placement and septicemia. The client is in this question with two risk factors: is the 25-year-old with a central venous catheter in place and a place to treat septicemia. All of the other patients have one risk factor. So this is a big question that they like to do on NCLEX. So when you guys look at these, when they're telling you which patient is high at risk, you're going to have to count their risk factors. So I'll bring another question like this, where you, like, one patient has 5, one patient has 4, one patient has 3, one patient has 2. So you have to count them out and see which one has the most. Now the thing with this, it told you you're a 50-year-old and that person is older, he or she, and it's a post-operative patient, but it doesn't really tell us what post-op, what did they even have, you know? So this 25-year-old, so that central venous is 1, and then the septicemia is 2, and then like they showed you. So you'll see questions where they'll put like 2 risk factors in, 3, 4, 5, and then you just have to count up which one has the highest of that, just because of the age. Yeah, so that age could be 1. That would be the first one. So Kristen, that was 71, but then it says otherwise healthy adult. So they only have 1 risk factor. That makes sense? Okay. And I'll show you guys, I'll pull some other ones of those because I like to show you guys those just because it's pretty easy to pick out the one, and it's pretty apparent, but it just, you need to know how to do it. All right. Avoid activities that cause venous stasis. So wearing socks that are too tight at the top or leave marks on the skin, crossing the legs at the thigh, or standing or sitting for long periods of time. Elevate the legs 3 to 6 inches higher than the heart letter. Encouraged to walk 30 minutes each day. If there are no contraindications, wear graduated compression stockings, and then overweight needs to be reduced, right? Okay, and if we have sores, we're going to look at those and treat those depending on what's going on with that. A lot of times we get wound therapy or the wound clinic involved with those patients. Anti-infective therapy depends on the infecting agent. Oral antibiotics could be prescribed. Compression therapy, where we do those boots, or do wrappings, kind of like a cast, or those uniboots, and then debridement of wound and dressings, depending on what we're doing. And then we know that's impaired skin integrity. We know we have impaired and we know we have nutrition balance on that. All right, and we're worried about infection and gangrene, right? We don't want that to get worse. Restoring skin integrity, physical mobility, adequate nutrition, and then we have to do cleansing wound positioning, avoid trauma, and avoid heat sources. So especially like heating pads, you have to make sure, just like that diabetic patient, that you're not going to burn them, or because they can't feel it as well. Okay. See if they're, and then we want to do pain medicine. If they're having a lot of pain, we want to do that before their activities. All right. Adequate nutrition, we're going to look at a protein, vitamin C, A, iron, zinc. Our older adults particularly consider should be given to their iron intake because older people are anemic. So that's a big thing that we'll do that CBC to look what their hemoglobin and hematocrit is. We look at less than 8 on our hemoglobin is when we start looking at blood, or even if they refuse to take blood, we'll look at iron supplements for them, oral iron supplements, to hopefully get them up gradually or as quickly as we can. But some people don't want to do that. And then here's the inflammation of the lymphedema. And you'll see there actually is I've worked with nurses who've had some lymphedema problems where their legs were so big and they thought it was like an arterial or a venous thing. And it was actually this lymphedema where the tissue swells related to obstruction of the lymphatic flow. And they said it's primarily congenital, but it can be acquired obstruction. But I've seen some, I mean, their legs are very large and they'll wrap them a lot, but if there's not a lot you can do with that, it's actually pretty bad. And I don't know if that's just years of on their feet, but I've seen a couple of nurses having this disorder. Cellulitis, we know we have what that is. You guys, has anybody seen any cellulitis, pretty bad cellulitis, where we get that infection and it starts streaking up? So we want to try to get that. Elevate affected area, warm, moist packs every 2 to 4 hours. I've seen it in med surg. Sometimes even if you're going to catch a cellulitis, you can like do a warm bath and try to soak it and then get out. Like, so say I've seen people where they get things like wedged into their feet. So say they get those little spiky spur things, and in your foot, you're stepping down, so it's getting impelled, or you get some kind of, it's either, what you'll see cellulitis, especially in Texas, is like a sting from like a bug, like a bee sting or something like that, or you'll get some kind of like splinter wedged in, like feet or hands, that kind of thing. Some kind of, Erica, were you going to say something? Have you seen some kind of cellulitis? She's like, no. All right. Educate regarding prevention of recurrence and reinforce education about skin and foot care. Okay, so we have to check them, make sure we check there if they don't have good feeling on that. And that is the last one. Okay, good deal. Okay, you guys, I want to quickly, real quick before you guys go, I'm going to end this and I want to show you some aneurysm stuff here real quick. Okay, so if we're looking at this, here is our aorta. Ascending, descending, circling around our arteries. And if we go down here, here's a picture of one that, this is an abdominal aortic aneurysm. So when you hear them say AAA, a common area for us to see aneurysms is down in that stomach area, and it's abdominal aortic aneurysm, okay? I showed you guys the true and false where they sacculate or fusiform. And then what happens is that blood flow goes in, it's got a tear in the skin there, and then that blood starts collecting. And then we saw where we can do the repair. So the same repair that we did up where we have that ascending aorta can happen down anywhere along that track. And they're going to put that new opening in there, or that, can't remember the name of it. Like it's like a polyethylene kind of sleeve. So here's where you can see where this patient had a dissecting one below the heart, above the kidneys. Now, if they have to fix one, when it gets a certain size, they have to, it's 4 to 5 centimeters. We watch it. If we start seeing one and say we accidentally, or we took an x-ray for something, they were having some abdominal pain. and we saw an aneurysm, then what we're going to do is we're going to measure it. And if it's between that 4 and 5 centimeters, when we're going to consider surgically repairing that, because we don't want it to rupture, right? So a lot of times we'll follow them. And then when it gets a certain size, it's a little smaller in a woman and a little bigger in a man, we'll go in there and surgically fix that. Now, when we're doing that, we're going to clamp the top and the bottom. Now, if it's above the kidneys, which a lot of times it can be above the kidneys, after we put that new sheath in there, we have to make sure that there's good blood flow to our kidneys. So what's the thing that we're just going to tell us that after we fix this aneurysm that we have, that we're going to have good blood flow to our kidneys afterwards? What are we going to track afterwards?
You're asking what are we gonna?
What are we going to keep track of, like
Oh,
in
urine.
what is it?
Urine output.
Yes, urine output, you guys. So we're going to make sure that we have good flow back in that area by, yeah, urine output. Exactly. So a lot of times when you see patients with these aneurysms, or they come in, a symptom that you can see and that you can think of is back pain. Besides back pain being pain in your back because you injured your back, but all of a sudden you get a patient in the emergency room, for instance, that's complaining of back pain. You want to put in the back of your mind, hey, this might be an abdominal aortic aneurysm, okay? Because that's a sign of an aneurysm, is back pain. So besides, it could be just back pain, right? Because they injured their back, but this could be a sign of an aortic aneurysm about to rupture or having been ruptured, okay? All right, and that's what it kind of looks like on x-ray. And then this was just another slide I put in to show you guys serum cardiac markers after an MI. So where you see the myoglobin, the CKMB when it peaks, and then the troponin. So how we have to keep them in the hospital to wait to see if they've had an MI, to see if our troponin elevates in that 8-hour time period. Usually we do 6 to 8 hours and then another 8 hours. So we keep them in that critical decision-making unit, that unit to kind of follow their EKG and look at their labs and stuff, okay? All right, guys, you hanging in there? Then we'll do some practice questions. I'll show you guys some pictures. We'll kind of review everything since we kind of covered it all at this point. How are you guys doing? Hanging in there? All right, I really want you guys to practice on your strips. And we'll so start looking at those. And then I'll pull some case studies too, so we can look at. And then you've got a couple case studies for the leadership ones to look at too. And I want you guys to do a report on those or fill out a report sheet. All right, guys, have a good night.
Professor Hall,
Yes.
These particular slides that you went over, they're on D2L, correct?
I can put these if you guys want. Yeah, the ones, yes, these are the ones that I pulled, the heart block and these pictures that I wanted to show you.
Okay, those are on D2L?
They are.
Or are they on top?
No, they're on D2L. I put the extra stuff on D2L. Let me look. I can cross over and look at D2L. Let me reassign this back to you guys. Assign for review. This one. Okay, let's look at, let's see if I have it pulled it up here. Slide this over. Okay, let's look at the content. Let's go here. Okay, and see if there was anything else I added. All right, so there's that heart failure one-page handout that I did. There's an acronym that you can use to kind of remember the different signs and symptoms. So I had typed that out. I found it on something else. So I put that on there for you guys to see. It might take a minute to upload here. These things were a little slow today. People are having internet connection problems. I don't know if it's because it's after the storm or what. Can you guys see that slide? I can't see it right now.
No, ma'am.
No, it's not pulling up at all. Okay, hold on.
I mean, it might pull up on
D2L.
later, but it's not
Yeah.
pulling up right now.
Okay, I'll look at that again. Let's see what else is on there. And we went through this other two. And then I put the EKG recognition and I just put you, and the rates are off a little, you guys, because I just actually put the rhythms on there. Okay, so you guys can look at those. And you can see this VFib is a little better. when Madison and I were looking at EKG strips yesterday, you'll know the difference when you guys are at clinical and you see a V-fib, it's kind of more of like a wavy. Whereas if a person's moving around on their EKG, if they're wearing a cardiac monitor and they're moving around, it's going to be really defined. Okay, to see that. And then the VTACs, the monomorphic, we're firing it from that same place. And this is another SVT going faster than that original one that was up here to show you. And you can't distinguish the P or the you can't tell if this is, more than likely that's a T wave, but you can't tell if that's a P or a T or what it is because it's going so fast. So that's a sign that that would be a supraventricular tachycardia, PSVT, or a PSVT where they add the P where it comes and goes, stops and starts fast. And then those are VTACs right here and here. Another version of SVT, just faster, which is going up higher. And then you see sinus Brady, normal sinus, and sinus tac. And then another example of VTAC, okay, with that wide QRS complexes. All right. Any other questions? All right, you guys have a good night. Study hard for peds. We'll see you guys at clinical. I'll stay on if anybody has any questions.